Good morning, everyone, and sorry for the delay. This is Caleb Cage with the Governor's Office, and we're going to call to order the December 17th meeting of the COVID Mitigation and Management Task Force. Megan, please call the roll and mark me present.
Absolutely. As a friendly reminder, you might need to press *6 to unmute your system. We'll go to Caleb Cage.
Here.
Richard Whitley.
Here.
Terry Reynolds.
Here.
Jamie Black.
Here.
Dave Fogerson.
Present.
Felicia Gonzalez.
Here.
Brett Compston.
Present.
Megan Worth Ranson. Here. Chris Lake.
Here.
Dagny Stapleton.
Here.
Wesley Harper.
Here.
Mark Pandori.
Here.
Kyra Morgan.
Here.
Lisa Sherrick.
Here.
Julia Peak.
Here.
Melissa Peak Bullock.
Here.
Melinda Southard.
Here.
Leslie Molenkew.
Here.
And for the record, Samantha Laddick.
Here.
Chair, you do have a quorum.
Thank you very much, Megan, and thank you for everybody once again for waiting while we took care of a couple of issues here. I'd like to move on to agenda item number 2. At this time, a couple of items that we need to talk about before we open the floor to public comment. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. Public comments may be limited to 2 minutes per person at the discretion of the chair. Committee's comments will not be restricted based on a viewpoint. Because there is no physical location for this meeting, public testimony under this agenda item may be presented by phone. To provide testimony by phone, please follow the instructions on the which are on the agenda. Make sure you press *6, identify yourself, provide public comment, and then press *6 again to mute yourself. There's not really a good way of going through and calling out individuals who might wish to provide public comment. I know that we have had issues with people providing public comment in the past, and so we've waited. But I know we have people who are called in and providing public comment, and I've called in myself to make sure the system is working. So we are going to go ahead and proceed. Will the first person who would like to provide public comment, please press *6 to unmute yourself, identify yourself, make public comment, and then when you hear the timer go off here, and that'll be the 2-minute point. So please, the first person, go ahead and begin.
Hello?
Yes, go ahead.
Hi. Hello, my name is Nicole, and I'm calling with Return Strong. I'm calling with concern over the handling of COVID within NDOC. NDOC stated on December the 9th that they will begin testing 100% of the inmates at every facility every week starting on December 8th. This has not started, and there are sick people everywhere. High Desert has 4,000 people with reports of sick people in almost every unit, yet no testing has been done, and that is a major concern. Also concerning is this letter I'm going to share with you from an individual at Southern Desert. To whom it may concern, I hope, and whoever this letter may reach, I have experienced a high level of anxiety due to COVID-19 due to my family outside being exposed and people being exposed in here. It's causing me to have chest pains and migraines, and I have not been provided with new masks since the original ones were provided. My medical needs are not being met, and I haven't had fresh air in 2 months. There's also no air conditioning in the summer or heat in the winter, and it's 35 degrees in the evening now. A lot of us have brought this issue up, and nothing has been done. We only receive sack breakfasts and lunches, and that's it. And I don't understand why I'm being forced to live in inhumane conditions and being condemned to death by COVID-19. Also, listed in the very agenda information provided by NDOC is riddled with inaccurate information, including the positivity numbers. In fact, contrary to the info about to be provided during this presentation, NDOC has 2,194 positive inmate cases and 561 positive staff cases on December the 15th. If they cannot be truthful with regards to information that can be obtained via another source, why should the information be considered as other information be considered to be accurate as well? Hiding the sick people without testing them to make their numbers look better is apprehensible. Thank you for your time and consideration.
Thank you. Will the next person who is here to provide public comment, please go ahead, identify yourself and begin.
Hello, my name is Jody, and I'm here today as a member of Return Strong Families United for Justice for the Incarcerated to read a letter from a woman incarcerated at Gene Conservation Camp to tell her experience of what is really happening in NDOC, not the story being told by administration. Last week, Director Daniels spoke about his levels of quarantine isolation and unexposed units, but the stories from the inside of the facility do not reflect what is really happening. Today, we are looking at the differences between theory and practice. Times are tough here at JCC. We have been locked down in our particular unit since 11/22 due to some outside exposure of COVID. We are tested not long before the lockdown, and again a few days later. Within the first round of testing, we were the only unit on lockdown, and those exposed were moved from camp. Then later my unit was locked down. After the second round was done and we got results in 7 days ago, more positives led to the whole facility being locked down. The exposure left, but then they began moving people around units. My unaffected unit took in 6 more people, and the unit became an isolation unit. It seems if anyone exhibits any symptoms, they're moved out of this isolation unit until transport arrives. When we were first quarantined, it wasn't too intense. However, now it's becoming a daily struggle with temperament and motivation to get up every day. I usually run 4 miles a day and now resort to staring at a brick wall and run in place to help kill the depression. The heavy oppressive anxiety and fear that has nowhere to go but in my head. It is intolerable. I am a nonviolent felon here on drug charges due to my own abuse. I am not a danger to anyone else or no longer a danger to myself. I expired my sentence in October and was supposed to be released October 8th, but I have had 3 parole addresses denied, including going home to my husband and children because he had a previous drug charge. I have been waiting for the program faithfully, but now it's off the table. I know people with money are not sitting in prison past their expiration date.
I need to interrupt you right now. That 2 minutes is up.
Thank you.
Thank you very much. We'll go ahead and go to the next public comment.
Hello, my name is Jenna, and I'm here as a member of Return Strong to share the experience of a woman incarcerated at Gene Conservation Camp. First, I would like to address my possible eligibility for any potential rapid release opportunity. I have a nonviolent felony that are all related to my past addiction. I do have a release plan, and my expiration is February 16th of 2021. I heard that the director ran a report to identify who would qualify for a rapid release. How do I not qualify? As a mother, the weight of an unknown has mentally, emotionally, and physically taken a toll on me and my loved ones. My 3-year-old daughter was exposed to COVID and has breathing treatments due to pre-existing conditions. Not knowing if she is okay or being able to be there to protect her has truly heightened my anxiety and depression. The issues here are horrible. NDOC is not coming close to keeping us safe from the virus. Enough is enough. We were given 2 masks to wear that are like gauze and do not fit or stay on. We have no hand sanitizer and minimal access to bleach. In the middle of this pandemic, I have been transferred to from Florence McClure to Gene Camp, and both facilities handle things differently. As NDS workers, we are still going into the community to work in Las Vegas. Some jobs requiring interaction with outside community members, which is how the virus entered this facility and resulted on the quarantine we are currently on. JCC is an open dorm, so once one person gets it, we are all exposed. My unit is negative, but cases are popping up in other units. Today, the lieutenant came into the unit to tell us we were going to combine 2 units together and move some people from one unit to another. Why? She wanted to move some women who have no positive cases to a unit who was just exposed last week. All night, we stressed about this idea, and it didn't happen yet because we were able to get them to see that it might just be dangerous. Every day, we are white-knuckling it, and it is causing tension to build everywhere. This whole situation is unbearable. Every day, we pray together that we make it out of prison alive. Yes, we have to pay our debt, but should we be paying with our lives because the director, wardens, and COs don't want to be honest about the consistency and danger they have allowed us to be exposed to? If we have an approved plan, let us be family.
Thank you very much, Jenna. I'm going to go ahead and go to the next public comment with 2 minutes being up.
Hi, my name is Jen, And I'm here with Return Strong to read a letter from an incarcerated person at Southern Desert Correctional Center who wrote to us to describe the conditions he is living under. I'm writing this letter to inform you of the conditions the state of and NDOC has left us in because of COVID-19. As of now, I have not felt the sun or breathed fresh air in about 2 months. There are no windows in this unit. We are locked down without heat, fresh air, breathing each other's breath. It is as though they want us to pass anything we have around to each other. It is so cold, it's like a meat locker. I can't feel my hands or feet. It's so cold, and every time we ask about it, it gets colder. I sleep in gloves and 2 sweatshirts, sweatpants, socks, and a cap. When I can sleep, some days I go without sleep because of it. The air is so stale in here, it smells like a locker room that has been closed off for years. There is so much dirt and dust coming from the vents, it's like living in a dust bowl. This cold, dirty air leaves me in consistent pain in my body. I am 59 years old. There is no get back if I catch this virus. Every time I put a kite in to see medical, they write back and say, due to COVID, they are not seeing patients. I don't know if I will ever make the list. Thank you for shining light on this situation and allowing me to voice my truth about what is really happening behind these walls. I can't put most of it into words. The state has thrown us away. It is genocide.
Thank you. Next public comment, please go ahead.
Good morning.
Hello.
My name is Rita Devine, and I want to give you guys another perspective from an outside person. I am a survivor of COVID-19. I'm also a victim of crime. My son was murdered December 11, 2017, and his murderer is housed in the Nevada Department of Corrections. I also work directly with the prison education program as the CSN program manager, but I contracted COVID-19 from my son, who was detained at the Clark County Detention Center. The jail was encountering outbreaks at that time, and unfortunately, he was grouped with others in a petri dish. Now, some of us experience COVID differently than others, but in my case, not only did it eliminate my energy, the cough and the body aches were absolutely horrible, but thankfully I had a comfortable mattress to lay on. I had access to soup, orange juice, and herbal remedies. Now, I bring this up because recently I received a call from one of my prison education students who have also tested positive and experiencing pains associated with COVID. It shocked me how concerned he was about his grades and his classes. And when I told him to go drink a lot of juice, get some rest, he informed me that they're not even providing them juice. Now, I share these scenarios as brief examples of what is happening, not just to them, but to all of us. And there's a lot of people that are inside NDOC. They're struggling. Some of them are soon to be released and or expired. But we're not talking about the population with lengthy sentences. We're talking about these individuals who need to come home. Now, it would relieve the state some additional expenses, but it would anyway. I just want to close by saying this: as much as I hate that my son's murderer, what he did to me, my son's identical twin, and his family, I wouldn't even want that man to die in prison from COVID. Thank you for your time.
Thank you very much. A quick reminder to everybody providing public comment, or everybody on the phone, if you're not actively speaking or providing public comment, please press *6 to mute yourself so that we don't have interruptions. Next public comment, please go ahead and identify yourself.
Hi, my name is Monica, and I'm here with Return Strong Families United for Justice for the Incarcerated to share a story and experience of a woman incarcerated at Gene Conversation Camp. The conditions are worsening here day by day. On November 22nd, all inmates were tested for COVID due to contact tracing resulting from a potential exposure of 2 inmates by an undisclosed source while on community assignment with Nevada Department of Forestry. On November 25th, the results came back and those 2 inmates were transported out of the camp. 2 units were placed on quarantine that day and all inmates were tested again. The results came back and 2 inmates in the unit that were not quarantined came back positive. Since then, there are now 16 inmates showing symptoms of COVID and the entire camp is on quarantine lockdown. My unit remains unaffected. As of this letter, we have not been allowed to leave the unit for anything since November 25th, which is the beginning to take toll on everyone. To be honest, I feel like a sitting duck with immense anxiety about not if, but when I will become infected with COVID, and with history of asthma and other respiratory elements catching, it really scares me. I have no control over this situation or my destiny. To me, this is inhuman to have human beings live in this type of fear. I am a nonviolent felon. My crime is addiction and drug related. I am for sure not a danger to the public. I have a lot of support and safe home to be released to. I'm curious if the governor would consider expanding house arrest guidelines to people like me. I don't want to die here, and if I catch this virus, I most definitely will. And I just want to end this. The person that wrote this letter did come back positive for COVID. So she's just basically saying the conditions at Gene Camp have drastically.
Thank you very much for providing your comment today. Will thank you, Monica. Will the next person who'd like to provide public comment, please identify yourself and begin?
Yes, hi, my name is Lola with Mass Liberation. I'm a volunteer.
Could you identify yourself again? I apologize. Someone else spoke while you did.
My name is Lola. I'm a volunteer with Mass Liberation.
Thank you.
As a community member, the lack of leadership at this administration and NDOC and the state of Nevada actually exhibit is appalling. We have heard today that there are nearly 3,000 people with COVID-19 in the carceral facilities. 10 people have died. 20% of those are DOC staff. The only option to speak to officials today is within an arbitrary 2-minute limit, which, as you can see, limits any chance to express any gravity of what's actually happening. This isn't about guilt or innocence. This isn't about crime or punishment. This is a public health issue. It's a public health issue that the state of Nevada, DOC, all have an obligation to solve. We have seen through this lack of leadership that DOC has effectively undermined everybody's efforts in the state of Nevada to stop the spread of the virus and flatten the curve. Excuse me. NDOC is creating situations that will overwhelm our already depleted ER and ICU beds because they're creating super spreaders within the facilities. People inside prisons won't be treated for COVID-19. Inside prisons, they go to the same ICU beds as the rest of the community. NDOC and the governor have a duty to lower the numbers in the facilities because statistically speaking, just statistics alone, the only way to reduce the number of COVID-19 cases in our already overwhelmed health system is to reduce the numbers of people who are exposed. We need a plan. You're hearing so many people speaking. You're hearing victims of violence speaking. It's not about crime or punishment. It's not about guilt or innocence. We need a plan that is going to prevent the spread of this virus, period. And I yield the rest of my time.
Thank you very much. Next public commenter, please go ahead and begin.
My name is Vera Moore, and I am the Director of True Beginnings Divinity Health Collaboration. I hear all of this, and everything is on the side of the problem. We need to start operating on the side of the solution, and the NDOC has not been very welcoming or permitting where that's concerned, where they're working with probation and parole not to let these individuals home. So NDOC is stating that they won't let the individuals home because there's no place for them to go, because the places that are open, that are parole and probation approved, are refusing people. However, we have several agencies, several housing components out here or facilities that are willing to take individuals that can be released, but they won't allow us to take those people because we have not paid to be licensed through the state. So this all comes down to a financial issue, an economic issue, where if the NDOC would to loosen some of the restrictions, we will be able to have housing for the individuals that have expired and the individuals that are coming up on expiration. So we can get those women and men out of the system and kind of loosen what's going on inside and start providing some services in there. And we know that when they come home, they would have more benefits, and they would have more structure out here with people helping helping them and helping them get over COVID, or preventing them from catching it, and we can stop the spread right there. So I think if we stopped wagering on the economic issue and start wagering on the humanic issue or the humanity issue, we will probably have a solution here, and we can come together so that these individuals can come home. So my thing is, with the governor not working with the NDOC and probation and parole to loosen these restrictions and allow the individuals to come home, just keeping them inside and killing them off one by one. So what's the solution? If we just kind of lessen those restrictions, we could get these individuals housed ASAP.
Thank you very much, Vera. Thank you very much, Vera. I appreciate your public comment. We will now go to the next public comment.
Hello, my name is Jennifer, and I'm here as a member of Return Strong Families United for Justice for the Incarcerated to read a letter from a person incarcerated at Gene Conservation Camp. This is just one example of hundreds, maybe thousands of people the director says do not exist. Nonviolent felons with less than a year to expiration and a release plan and a home to go to. First, my case is nonviolent, and I do have a place to go when released, a home. I work for NDF, and we go out and work in the community. They say that 2 inmates were exposed while working, and that is how this started at Gene.
What am I wearing?
Now we don't leave our units at all. Everything is brought to us: breakfast, sack lunch, dinner, supplies. Each unit can house 48 inmates. The way we are housed, there is no ability to social distance. If one inmate gets COVID, we all get it immediately. We may have made choices that led us here, but the injustice happened before we ended up in prison. This was my first offense, and it was nonviolent. I didn't get the chance for probation or house arrest. I went straight to prison. My crime revolved around money and really around poverty and trying to survive. I was trapped and needed to provide for my family, and our country is not about everyone surviving. It is about some people thriving and other people struggling to survive. I regret the decisions I made, but making decisions under pressure is never a best-case scenario. I expire my sentence in July 2021 and live every day terrified that I won't make it to that day to see my children and grandchildren and hold my unborn grandbaby. The director says no one qualifies for any type of rapid release programs, but I am a nonviolent, expire in 7.5 months, and have a release plan and family to go home to. Why is he taking a risk with giving me a death sentence? Thank you for your time and consideration.
Thank you, Jennifer. We'll go to the next public comment.
Hello, my name is Sean Navarro. I'm the co-chair of Las Vegas Democratic Social America, Las Vegas resident. Most importantly, I'm a human being with a basic level of empathy towards other people. Since the beginning of COVID in March, medical experts and activists have been warning NDOC of the unique threat COVID poses to our incarcerated population due to incompetence or lack of caring, or probably both. No one listens, And what's happened right now in the prisons is a massive human rights disaster, on top of the daily human rights violations that come from being in prison in America. It's a violation of these people's 8th Amendment rights. No one should be forced to endure cruel and unusual punishment. It's unimaginable that this has to be said in the 21st century in the richest country in the history of the planet, but no one should die of COVID while in prison. If we have the money to imprison these people, to put more people in prison than any other country in the world, we have the money to ensure their basic safety. We as a society should have the basic decency to protect the people we incarcerate, but the spread of COVID affects the entire community as well. In Chicago, one study linked that almost half of the cases in Chicago to people who came from prison or recently reintroduced. Here locally, in the past 3 days, there have been 900 new cases in the NDOC. In Washoe County, a county with over 31,000 cases and rising, 90% of the local prison, the Warm Springs Correctional Facility, tested positive. Again, this cannot be allowed. This is a huge violation of people's rights. This is a huge safety risk to the general public. A few things that we need to see is decarceration. There's many ways to inexpensively and humanely transfer folks from these overcrowded prisons to the medical centers, to mental health centers, to prison them at home. We need to meet the current needs of the incarcerated, meet their basic needs, get them the vaccine, make sure they're well taken care of, and stop it from spreading further. We need to have independent investigations into the handling of COVID-19 in our prisons.
Thank you very much, Sean. I appreciate your comments. We're going to go ahead and stop there. Thank you very much. We'll go to the next public comment at this time.
Hi. My name is Ayana. My name's Ayana. I'm a member of the Return Strong. I have a letter also from an inmate that is at Southern Desert Correctional Center, and it reads, I am a 57-year-old man with chronic illnesses as well as mental health issues. Please help me. I don't want to die in prison. I wasn't sentenced to death. As I sit here in the cold box, no heat or extra blankets, and my mental health failing due to this pandemic, I was sentenced to 2 to 6, not the death penalty. But yet every day I am counting down the days as if I were. I know I committed this crime and take full responsibility for my actions and have taken the steps to fix me. However, I can't fix diabetes, which leads to heart diseases, and sometimes I am so stressed out and not knowing if I'll ever see my children again. My mind is playing tricks on me. I have never seen a penitentiary that has no staff. It takes 8 to 12 weeks to see a doctor, or maybe they never see you. I graduated the trust program and aftercare and was enrolled in reentry. I completed a victim empathy and was told I can't receive my days, and I am watching them run away from me. It seems my life has. I don't deserve to die here. How can we get the governor to consider releasing people like me to our families or on home confinement? Is there anyone that will help? Thank you.
Thank you, Ayana. We'll go to the next public comment.
Good morning. My name is Denise, and I am here today with Return Strong, Families United for the Justice for the Incarcerated, to read a part of a letter that we received from Dean Conservation Camp. I am incarcerated at JCC. You said that you're here to be our voice. Well, I am here, and I am a voice for all of us in here. Here are a few things going on. First, on November 25th, 2 inmates tested positive for COVID and were sent back to Smiley Road. They were in the same unit, and we went into a complete lockdown. COs began carrying everything into our unit for us, like food trays, but also COVID, because they would go into the infected units and then come out and right into our unit. The officers all go in and out of the units without changing PPE. Tray racks go in and out and are not cleaned in between. There is no access to grievance forms, and we have no signs on how we can contact the ACLU. We have one medical person only a couple days a week, and that person floats between here and Smiley. The lieutenant and senior officer never have gloves on, walking from unit to unit. Regular officers do, but they do not change them in between positive and negative units. The food they serve is expired, moldy butter and rotten carrots and celery, and we were told to cut the rotten parts off and serve the food anyway. There is no maintenance, so we are exposed to breathing in the sewer. The water is brown, and that is how we're supposed to drink it. That's the water that we have. We do not have heat or hot water, and we keep asking for them to fix it, but are told there's no one available to fix anything. Here are some people in my unit that should qualify for rapid release program. Me, nonviolent felonies. I have a release plan, a place to go, and documented high-risk medical conditions. Person number 2, also nonviolent, high-risk medically, and have a place to go if released. Number 3, nonviolent felonies and has approved place to go. The list goes on for another 30 people at least, just in this unit. The overwhelming number of women incarcerated are nonviolent, have families, and now are COVID positive due to the negligence of the state.
Thank you very much for your public comment. We'll now go to the next public comment.
Hello, my name is Ian Bigley, and I'll keep my comment brief. I'm a lifelong resident of Reno, Nevada, and I am calling in to say that the fact that so many people experiencing incarceration in Nevada right now contracted COVID is unacceptable, and it's evidence of just the utter failure of our government to manage this pandemic and protect the health of Nevadans. As many people have already mentioned, we need immediate relief through compassionate releases for medically vulnerable folks with within months of expiration and utilization of the pardons board. We need to improve conditions on the inside based off of listening to folks who are experiencing incarceration, and also we need an investigation of how and why we've experienced such an absolute failure in the state's public health. Thank you.
Thank you, Ian. We'll go to the next public comment.
Yes, my name is Darren Scheidel, and I'm here with Return Strong, Families United for Justice for the Incarcerated, to read a letter from an inmate incarcerated in DOC. During the pandemic, and to voice our concerns as a community to the validity of Director Daniels' claims to have this pandemic under control, and to call for an independent investigation into the claims of the DOC in light of what incarcerated people are expressing. The letter reads, I am an inmate at Southern Desert Correctional Center. I'm located in a dorm with approximately 100 other people. We are in the trust program and have been on quarantine 24 days since November 2nd. We normally have programming with counselors, but we are now on a non-programming quarantine. We have valid questions. If we are not programming, why are they still bringing in counselors from the outside if we have 0 positives? Their answer to those people need to collect a check. Then the free staff medical COs don't always wear masks. We have to use the same mask since we got to prison. For me, that was April 27th, 2020. If our mask is damaged, they charge us for them. Most COs have beards or facial hair, so the N95 masks are ineffective. The COs are serving food now, and they do it without proper PPE. Gloves, masks, hair nets. We live in a dorm and program on our bunks about 2 feet apart, passing sign-in sheets, journals, folders, and yet we are not allowed to go out to the yard and get air and sunshine and move, which makes no sense. Because if we're in a unit together 24/7, if one of us gets sick, we all get sick. Why can't we have yard time, which would help us all stay healthy? Most of us have not been outside for over 30 days. We don't get cleaning supplies. And it isn't like this is a hotel. They don't clean for us. No mops,
Darren.
bleach.
Darren,
Yes.
thank you for your public comment. Your 2 minutes have expired. We're going to go to the next public comment now.
Thank you for your time.
Thank you. Next public comment.
This is Debbie DeVal from Las Vegas. Can you hear me?
Yes, Debbie, go ahead.
Okay. I have questions for Dr. Pandori. As part of your presentation, can you address these questions? Let's see. How do you know the cell culture that you've done in your lab is actually detecting SARS-CoV-2 infection? Also, how do you know it's not just any type of infection that you've actually cultured? Second question, is there a better test that can be used than a PCR test to detect this virus? I know of someone who went to the Cashman Center for a COVID test, and they said that you yourself put the swab into your own nose. Doesn't this affect the amount of specimen collection? And can this affect the outcome of the testing? My next question is, where do these testing kits come from? Are they made in China, the US, or where? How many different companies are being used? Can the variety of test collection kits affect any PCR testing outcomes? Just one other thing I wanted to say, after listening to these Return Strong callers, I would like to recommend that those incarcerated should have access to vitamin C, vitamin D, zinc on a daily basis, and any other proven prophylactics that could help the prevention of catching the virus or even helping it be a minimal effect. This could help strengthen their immune systems, and this could help reduce the spread, take away fear, and impact those who contract the virus with better outcomes. Thank you.
Thank you, Debbie. Next public comment.
My name is Tiara Moore. I'm also a volunteer with Mass Liberation. I just want to say, to stem the spread of this deadly virus, we must drastically reduce the number of people inside of jail and prison and offer some compassionate release to nonviolent offenders. This is a matter of life or death. We see and understand what's happening on the ground with this pandemic, and for our humanity, public health, and public safety, we need to allow these people to be released. Thank you.
Thank you very much. Next public comment.
Hey, this is Matthew DeFalco for the record from Henderson. I just want to say that I think it's abundantly clear that the crowded and unsanitary conditions in our prisons and jails facilitates the rapid spread of the virus. Military veterans sometimes run into issues with law enforcement and the criminal justice system that result in incarceration. In fact, a report from the U.S. Department of Justice Bureau of Justice Statistics shows an estimated 181,500 veterans were in federal prison and local jails at one point in time, which is about 8% of all inmates. Incarcerated veterans are at risk and need to be taken into consideration. I encourage you to consider lowering the number of people behind bars in both jails and prison facilities, meeting the immediate needs of the incarcerated people by improving conditions on the inside, and an independent investigation into the handling of COVID-19 inside our facilities. Thank you.
Thank you, Mr. DeFalco. Next public comment, please.
Hello? Hello?
Yes, go ahead.
Hello, my name is Michael Kelly from North Las Vegas, and I am the chair of the Nevada Democratic Veterans and Military Families Caucus. And I am, and you as a veteran would understand, we have many veterans incarcerated in our facilities at NDOC as well as throughout the state, the county and municipal facilities. For the past year and a half, we have been advocating for an increased usage of community corrections to try to resolve issues relating to veterans, because we felt that they were at risk inside our prison facilities, prison and jail facilities, and we asked for a comprehensive plan. So far, that has not happened, and I have once again am urging you, as well as working with our legislature, to develop a comprehensive plan for the use of community corrections. Many of the offenders we've heard about today are inside these facilities for nonviolent offenses. We need to utilize more inexpensive models, more effective models, in order to prevent recidivism, and we need to come up with a 21st century plan to resolve these issues. Once again, we urge as a caucus the use of outreach teams. We have tried for over a year to develop a veterans outreach team that would not only resolve the issues relating to veteran suicide and other issues relating to veterans, work with veteran offenders to ensure that they're not repeating the same offenses, as well as to ensure that veterans who are at risk for offending would be able to be, those risks would be mitigated. Again, we ask for your support when we promote these future plans to try to work with our city, county, and state government officials in order to ensure that veterans are being taken care of. And you as a veteran, we ask that you take this into consideration, Mr. Cage, and thank you for your service, and thank you for consideration.
Thank you very much. Next public comment, please.
Hi, my name is Madeline Williams. I have been a lifelong resident of Reno, Nevada, and I'm also calling to encourage this board to do the humane and the right thing in the face of 1 in 5 people infected in the NDOC and 10 people dead already, to implement some new strategies in the face of all of these problems, including compassionate release, but also including considering all of the bids for early release or for release that should already have happened based on the other letters that we've already heard read here today. Most of all, you need to listen to the people incarcerated, considering that many of the NDOC's reports are in direct conflict with the things that inmates have reported. Furthermore, we need more transparency from you and from the NDOC going forward on what the conditions are truly like. We shouldn't have to rely on people sending letters out to understand the treatment and the lack of resources that are present in our correctional facilities. This is literally a life or death situation, and if you don't do something about it, you are complicit. Thank you.
Thank you very much, Madeline. We'll go to the next public comment.
Hi, my name is... For the record, my name is Annette For the record, my name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. I'm here today because our organization is incredibly concerned about the situation happening in our jails and prisons across Nevada. As we enter the holiday season that is based in love and compassion for others, I find it reprehensible that we would continue to allow COVID to ravage our systems and turn a blind eye to the human toll it's taking on the incarcerated population. As someone who is raised Catholic like the governor, this is against our basic tenets that we were taught in our religion. As Pope Francis said about the inhumane treatment of prisoners, we will be judged on this. I do not care whether a person is incarcerated or not. These are human beings we are discussing, and everyone deserves access to basic human rights. The state has a responsibility to care for people no matter where they are or what has happened in their past. The state should be held liable for the safety of all incarcerated people. You have a moral obligation to focus on decarceration to meet the needs of all inmates and keep them safe. You need independent investigation into the handling of COVID-19 inside all facilities. You must focus on transparency and aggregate data as well as publicly tracked data on COVID-19 inside county and city detention facilities, and a commitment from our governor and this committee to address these issues in a real way. The way we have handled this so far is unacceptable and inhumane, and our organization demands that you do better. Thank you.
Thank you, Annette. We'll go to the next public comment.
Good morning. My name is Griseta Castro. I'm calling on behalf of Mass Liberation and Plan. I just want to echo everyone that has been speaking today during public comment. I know some stories are really heavy to hear, but that's because it's real. This is happening not only to incarcerated folks, but to their families as well. COVID is horrible. I experienced COVID in October, and symptoms are different, and especially within Black, Indigenous, and people of color. And it's horrible that there's not any actual medication for it, just taking home remedies or whatever is accessible to you. I know this starts with also lowering the numbers of people even going behind bars. That's caused by over-patrolling in communities of color. So I want to just address that as well. And we also have a pardon board, so I want us to utilize that and use what is within our reach. I also just want us to continue being transparent. I want y'all to be transparent and to let the public know of the data that's going on within the county and city detention facilities. And yeah, like I said, I just want to echo everyone that has been speaking already and really ask to help our community, please. Thank you.
Thank you very much. We'll go to the next public comment.
Hello.
Hi, go ahead and identify yourself and provide your public comment.
Sure. My name is Kenya, and I'm a former mental health employee for the Nevada Department of Corrections. And I'm here today as a constituent and as a volunteer of Mass Liberation. The circumstances that we see in front of us are not new. The NDOC has a history of falsifying information and not giving resources, even when they have them, to the people in their care. This is a human rights crisis. I'm also coming to you from the perspective as a COVID survivor and someone who has lost family members due to this uncontrolled pandemic due to lack of leadership.
We'll make sure you have time to provide comment. If you're not providing comment directly right now, please do mute your system. Please go ahead.
Yes. I want to make sure that we utilize all resources we have of relief, which can include home confinement, electronic surveillance, compassionate release, utilizing our pardon board. That is what they are there for. And I highly suggest that we all look in ourselves and realize that these are humans and that we are being complicit if we are not doing anything about this. This is not political. This is not an issue of punishment, as has been said before. This is an issue of basic human rights, which NDOC has a history of violating. It is time to stop, and I strongly encourage you all to take action on this. Thank you so much.
Thank you very much. We'll go to the next public comment.
Hello, can you hear me?
Yes, we can. Go ahead.
Hi, my name is Martha Menendez. I am in immigration here in Las Vegas. I'm calling today as a constituent. As many have echoed already, have said before, I'd like to echo that. It seems to me that what has happened here and the response in the prisons and the jails to this COVID epidemic just really highlights issues that have always been present. For me as an advocate, as an attorney, the most pressing thing I think is transparency. What we're hearing from incarcerated folks in comparison to what we're hearing from officials just completely doesn't vibe. So it becomes very difficult for the public to have any trust in what we're hearing. As we've heard this morning already, conditions in there are egregious. They've probably been that way for a very long time, and this is only highlighting it. And it also highlights how little we care about the lives that, as Nevadans, as a state, we are supposed to be protecting. In spite of whatever criminal record people have, they still deserve to be treated as human beings, and we are clearly not doing that. I would stress also not just to be transparent with the public, but to give people on the inside the information that they need. I hear from clients all the time that they have no idea how many cases there are where they're living. They aren't, they get sick and they won't even take their temperature sometimes. It's almost like retaliatory. If they complain about anything, then they're really not going to be seen. And so that's what I'm hearing. And I would just really stress that we need real, clear information we can trust. And that's really only something that you all can help us with. Thank you.
Thank you very much for your comment. Is there additional public comment at this time?
Hello.
Hello, can you hear me?
Hello? Oh.
Just
Hello?
one at a time, please. Go ahead.
Oh. Hi, my name is Yesenia Moya. I am with Vegas Freedom Fund, and I am a constituent and community member. We need a plan that will put human life at the forefront. Lack of leadership within the DOC has resulted in thousands of infections and many more deaths to come. I urge you today to commit to yourselves to not be a part of the problem and to not have more blood on your hands. We need a plan that will put human life like I said, at the forefront. Stop sentencing people to death by forcing folks to stay in what can be a petri dish. Conditions have obviously worsened, not that they were better in any instance before. And as an immunocompromised person, as someone who recently had warrants, I feared for my life. For a month and a half, I have been fighting these tickets for over 4 years, and I did not want to get arrested. I didn't use my car. I was out. I was forced to go into court to pay for my tickets and for my warrant, again, creating another public health crisis. We have heard many stories today from inmates and from folks that have been affected by COVID. I urge you to make a plan in which we will have things like release dates for folks, abilities to go in front of the pardon board, home confinement, release people within months of expiration, utilization of every effort that we can have on the ground, because folks are dying and it's not fair and it will be blood on your hands. Thank you.
Thank you very much. Next public comment, please.
Hello, can you hear me?
Yes, go ahead, please.
My name is Erica Minaberry. That's ErikaMinaberry, for the record. I'm working with Mass Liberation, and I am reading a letter with consent from an incarcerated person. I contracted COVID-19 due to negligence of the warden, NDOC officer, and staff. I'm at Warren Springs Correctional Center. There has been no medical care since being diagnosed positive with COVID. I submitted a complaint of a headache and issues with my blood pressure. I have still never seen a doctor or a nurse. 90% of all inmates in this prison have contracted positive. Staff informed me when I complained of labored breathing that they didn't have equipment to help me. We are all quarantined, and I am only outside 20 minutes out of every 24 hours. I'm deeply depressed knowing that I'm going to die because I am high risk. I have one mask, no cleaning supplies for my cell. I have told my family of the neglect and all that has happened to me and told them that I'm going to die and the state is responsible. This pandemic isn't their fault, but the mistreatment and the neglect is. I have a hard time reading that, and I hope that the governor had a hard time hearing that. And if the governor does not take action on this immediately, every person that dies in our unjust and overcrowded prison system lies on his hands, and may God not have mercy on his soul. I relinquish the rest of my time.
Thank you. Next public comment, please.
Hello, can you hear me?
Yes, go ahead.
All right. My name is Sarah Coyle, and I'm a resident of Reno, Nevada. For the record, I'm calling as a constituent, and I will also be reading a letter written and shared with an inmate's consent. Greetings. I am writing to you because my family cannot pull off the miracles you've been able to. I'm praying you can help with these inhumane conditions, or at least some of them. The heater is broke more often than it is fixed, so it feels like I sleep outside and wake up outside. The way we are fed and the food we are given, you'll think homeless shelters are afforded better luxuries. If you are one of the few fortunate enough to have money, it may do you little good, if any. This pandemic has taken its toll on all of us, including my mental health. I've been diagnosed with bipolar depression, ADHD, and anxiety, amongst other things. I know I need to keep my mind at ease by focusing on something positive, like programming, working, or progression. But this quarantine shut everything down, and I've never felt so alone in my life. It's like my life and freedom is at the mercy of the NDOC. So even though I've been accepted for minimum custody, even though I'm doing good, even though I'm on a positive road, it doesn't matter because I'm stuck in one place, which is one of my greatest fears I developed in prison. To be trapped at the mercy of my own thoughts, reliving the memories of the past. And after acceptance of my past sets in, regret comes, then remorse for every lie, action, and thought that caused harm. For 9 years and 3 months of my life, the mental punishment has haunted every corner of my mind on a repeating cycle, and since the pandemic, it has only intensified. I am the furthest thing from perfect, but I am so much better than I once was. And anyone with 2 eyes and a beating heart will say so. I had nothing but a bad reputation in the eyes of society when I was sentenced to 30 years with a 10-year minimum. Since then, I've earned a GED, a diploma, archery. Sorry.
Sarah, I apologize for interrupting you. Your 2 minutes are up. We'll go to the next public comment, please. Next public comment, please.
Hello. Hello. You hear me?
I can. Please go ahead.
Hey. Hello. My name is Jovan. I'm with the Mass Liberation Project. I'm calling just to let people know that you cannot social distance in a 6x10 cell with another person, with another individual in that cell. That's impossible. We have federal guidelines right now where we're supposed to 6x6, 6 foot social distancing. You cannot do that in a cell. Most of the time, these individuals are locked down for 23 hours out the day. I know I can't wear my mask 23 hours out the day. There's at a point in time where I have to eat. There's a point in time where I have to sleep, and that's just not possible. And, we have to look at it like this. Businesses are required to be at 25% occupancy. Prisons are businesses too. They take contracts with the state, take contracts with the county. So we need to let people go home. If they could go home, we should allow them to go home. If they have a place that they could parole to, they need to go home. If we could allow people to have single cell livings, they're able to protect themselves from COVID. They're able to social distance, and they can have a peace of mind, because having that type of anxiety, that type of stress on you with another person in that cell, it will drive you crazy. So, we have a governor that, wants us to operate at 25%, for businesses. So I would like to see the same for the prison system out here in Nevada. Thank you.
Thank you, Jovan. We'll go to the next public comment, please. Is there
Hello,
additional
can you hear me?
Yes, please go ahead.
Hello, my name is Lois Barron. I'm calling on behalf of incarcerated individuals with the Mass Liberation Project. I would just really love to imagine the possibilities if you made progressive decisions, such as letting these people go home. It would be so wonderful, I'm sure, for you and everyone else to have a meeting where public comment was congratulating you on taking the measures needed to protect your citizens. These are human beings and they're dying with a death sentence in jail. Listening to these letters sounds like listening to letters from a third world country, and we can do so much better. I know that nobody wants it on their consciences to have people dying in jail when they are in there for nonviolent crimes and when they could be easily at home for the holidays with their families. The fact that some people have only received masks one time when they entered in April, people don't have heat, people aren't having vitamin C or the sunshine, is not only inhumane, it's reprehensible. I really hope that you decide to make a good decision and that maybe Nevada can be an example of what to do for the rest of the country instead of an example of how exactly not to help people and how to treat people like expendable bodies of meat. I've never heard anything so sad in my entire life, and I really would love you to imagine the possibility and use the power that you have to allow these people quality of life and equitable conditions like all of us are afforded. Thank you.
Thank you, Willa. We'll go to the next public comment, please.
Hi, my name is Jonas Rand. I am a resident of Paradise, and I just wanted to echo the comments made by others to the effect that it's unconscionable for us not to address the issue of people facing incarceration in the middle of this pandemic and not investigate it independently and not pursue expediting the release of people, especially scheduled for parole, but also in general to ensure compassionate releases and to ensure that people can be home for the holidays with their families if it's possible. It is impossible, as others have noted, for people to follow adequate procedures given current circumstances and restrictions and given the nature of the pandemic. And so I think it's important to recognize that, shocking things have taken place, as others have elaborated, behind bars that deserve to be addressed, and that people do not deserve to be held in conditions like that. And it's disgusting and reprehensible to not have taken action until now. Thank you.
Thank you, Jonah. We'll go to the next public comment, please.
Hello, my name is Jody Hocking. I am the founder of Return Strong, and as I think you all are aware, we've been calling now for months, following the footsteps of other activists who have been calling since the beginning of the pandemic for different solutions. There are so many examples of best practices that are out there that have just been ignored by Nevada. We've taken the word of NDOC as the truth, and that we continue to take that and not listen to people who are actually experiencing something that's very different. Not having enough food, not having staff, being disrespected by staff, not being able to get medical treatment or Tylenol or any of those things. We have called and called and called about what the problems are and put the spotlight on them. And there was someone earlier on the call. It's time to shift to finding solutions. We know what the problem is. If the governor, if the task force, if whoever needs more proof or more information, we have hundreds of letters and we get another 50 to 100 every day. Just ask us. We'll be more than happy to share that information with you. In addition to rapid release, we've listened to the director say that nobody's eligible. Return Strong has manually gone through the Department of Corrections' own parole eligibility list and have identified over 1,000 people that could be eligible and be home already. We look forward to really sitting down and finding solutions to these issues and putting them into action. The people that came before us, MassLib and the ACLU and a million organizations, I wish I could name you all were calling for this when the pandemic first started. We've talked about it. Let's do something.
Thank you very much for your comment. We'll go now to the next public comment.
Hi, my name is Courtney. I'm with Mass Liberation. So people talk with their families and we understand our loved ones inside are struggling. The system is more invested in the private companies providing slop to prisoners and the money they are getting from the labor of inmates. Even before the vaccine, we should still have been trying to mitigate the spread of COVID. Would you like to be inside for 30-day periods, getting 15 minutes to call your family and take a shower every 3 days? No, people on this committee get to see their family. You all get to go to the store, bars, travel. So please do not act like you know what these people are going through. They are community members just as much as you all. I'm sure that if you went through this, you would go literally insane. These inmates are strong and they should not have to be. Incarceration should not be a death sentence. Inmates deserve vitamins, yard time, decarceration methods, so some of our community members can return and will return to us alive and healthy. The independent investigation everyone is calling for is because NDOC obviously cannot handle this themselves. We have to listen to them. We should listen to inmates just like you all are listening to us today. Why is there no accountability within our system to make sure that incarcerated folks are being treated humanely? I challenge you all to set a day to listen to the people who are the reason you're sitting here today. They made a mistake and they deserve staff in the system to treat them with respect, something you all keep showing you're not capable of. The thing about nonviolent versus violent in regards to these people is that they do not deserve to die or to be treated inhumanely regardless of what they are in for. They deserve true rehabilitation and care. How do we release them if they come out even worse and more traumatized than they already came in? That is the epitome of recidivism, which again fulfills the system's need. The lengthy sentences and this whole tough on crime, it fueled mass incarceration, and it's been proven ineffective and inhumane, especially in response to violence in our communities. And it runs counter to the demands of violent crime victims for investments in prevention rather than incarceration. Thank you.
Thank you very much, Courtney. We'll now go to the next public comment.
Hello.
Hello, please provide your comment.
Hi, my name is Tanisha Freedom. I'm a concerned citizen and lifelong resident of Nevada. I'm trying to raise concern about the city, county, and state failure to those that are held kidnapped in various facilities across the state. In my own brief detainment at CCDC, I witnessed no proper hand-washing facilities, filthy cells, no social distancing, no masks, and staff both overwhelmed and unconcerned with the safety to those that were held. The proof is the cases are increasing, not decreasing, and that is without knowledge if proper testing is even occurring. Something is not going right. Some of the shocking and recent stats that I read was that approximately 2,800 incarcerated people and/or 1 in 5 are impacted, and 10 people have died, including your staff. These men and women do not deserve a death sentence. We know these facilities struggle with providing proper food, decent housing, and medical care without a global pandemic. We're hearing an increased mental health breakdown because of the trauma associated with the restricted confinement as well. We are the community, and now we are the jury, and we are finding the state guilty for neglect and death due to an improper response to the handling of COVID and those held kidnapped. We demand that the state respond to the people's call to release all nonviolent offenders, those awaiting trial, and those that are currently held expired. Allow the community the opportunity to care for our own people and our own families. I yield my time.
Thank you very much. We'll go to the next public comment. Is there additional public comment at this time?
Yes, this is Leslie Turner with Plan Action, the Mass Liberation Project. I'll be very brief. I just wanted to put it on your radar that there is a report that just came out a few days ago by the Prison Policy Initiative, which really talks about how these outbreaks within prisons are connected to outbreaks that we're seeing in the community. So there's a direct correlation between the kind of like spikes on the inside and then community spread. And so I just really encourage everyone to take a look at that data. And I mean, we saw that here with 90% of the population at Warm Springs, that kind of blew up at the same time that Washoe was, didn't even know if their infrastructure could support the number of cases that were positive for COVID. So I just encourage people to look at the data, really consider solutions that are outside of the box, because we cannot keep doing what we've been doing. This is a new problem that we're dealing with, and we've never actually dealt with it before. So I think that there's clearly and what's happening at the top. So whatever policies and procedures that NDOC's management is saying is happening are not actually being carried out on the ground. I said that last week, and I'm going to say it again, because as you can hear that we're continuously getting letters, hundreds of letters from people inside that are explaining what's going on. We've read a lot of those letters on these calls. And so someone uninvolved has to take a look at that. And we have to start listening to the experiences of incarcerated people, because it is not matching the protocols that are being reported. And yes,
thank you very much,
Nevada,
Leslie. We appreciate your public comment.
Okay.
We'll go to the next public comment. I want to make sure there's plenty of time for additional public comment. Is there additional public comment at this time?
Hi, this is Jessica Peterson.
Hi, Jessica. Go ahead, please.
Hi, my name is Jessica Peterson. I sit on the board for the Friends and Family of Incarcerated Persons. I'm also a defense attorney in the Valley. And just from hearing from families as well as individuals, there is an outbreak at the Nevada Department of Corrections, the Clark County Detention Center, in both of those facilities. It is both dangerous not only to clients, but to those families once they are released and back to their homes, but also to those within the legal community who would like to provide adequate quality representation to those individuals. I know that there's also an issue with clients who are, or individuals who are up for parole, have COVID, and then delayed that time in which they are going to be released back into the community, meaning that they could succumb to either having COVID again or succumb to their injuries because they're not being provided adequate quality health care. So I implore those who are on this committee to really consider and think about the lives and the individuals who are being housed at NDOC, at the Clark County Detention Center, as they are human beings who deserve to receive the same amount of respect and the same amount of health care that anyone else who is on the outside has been receiving. Thank you.
Thank you very much, Jessica. Now go to the next public comment. Is there additional public comment at this time? While we await any additional public comment, I'll remind everyone that we'll have another opportunity for public comment at the end of this meeting under agenda item number 9 with the same procedures for providing public comment during this portion of the meeting. Also, in your meeting packets for the members of the task force, as well as for members of the public who are providing input or who are looking for documents related to this meeting online, the Nevada Health Response website, which provides all the meeting materials for this meeting, has 6 additional copies of, or 6 additional public comments that have been provided in writing. Please make sure you're reading those and understanding those comments and perspectives as they're provided as well. At this time, I'd like to call one more time for any public comment that any member of the public would like to provide now.
Hi, my name's Emily Driscoll. I'm a Nevada voter, a Boyd Law student, student attorney, and student president of the National Lawyers Guild. I'm calling in regard to COVID and NDOC. I implore Nevada Health Response to facilitate 1, decarceration by means of releasing the medically fragile, using pardons and early release for upcoming expiration, and using pardons just to start. 2, meeting incarcerated people's needs by providing access to sanitizing supplies, PPE, and regular testing. 3, conducting an investigation into the NDOC and the state's fumbling of the COVID-19 crisis that has caused negligent and wrongful deaths of incarcerated people. And 4, transparent and accurate data collection as incarcerated people continue to contract COVID and die in Nevada. As incarceration per person costs upwards of $40,000 per year, it is incomprehensible that decision makers and NDOC are unwilling to provide basic services to their wards in carceral facilities. It is clear that NDOC is using COVID as an excuse to further repress people's civil rights and denying them access to these activities and contact with family and friends on the outside while they continue to get sick on the inside. If not for humane reasons, Nevada should, at minimum, meet these 4 demands to mitigate costly future lawsuits that will inevitably burden public budgets and humiliate the state. COVID deaths in carceral facilities are avoidable if only the state handles that issue correctly. I yield my time and thank you all for holding this public comment.
Thank you, Emily. We'll go to the next public comment. Is there any additional public comment at this time?
Hello.
Hello.
Hi, sorry about that. My name is Laura Martin. I'm the executive director of the Progressive Leadership Alliance of Nevada. And I definitely lift up everything that folks have been saying, especially the leaders from the Mass Liberation Project. And I hope that we can remedy the situation because it's something that's been brought to the governor's office as far back as March 27th, raising the alarm about the possibilities of COVID spreading throughout our prisons. Unfortunately, we've been misled by the Department of Corrections, and now we're seeing that people are literally dying. These aren't just cages that people have been held captive in. They've now become their tombs. And like the previous caller just said, this is going to open up the state of Nevada, whose budget is already hurting. We've already defunded our education and healthcare programs. And now it's going to affect our state in terms of civil lawsuits that'll come from Governor Sisolak's inability to protect people who are incarcerated. And we also have to remember, being in jail doesn't necessarily make you a bad person. And a lot of the time, it doesn't even make you guilty. We just passed legislation to compensate people who were wrongly incarcerated in the state. I pray that there's no one in this jail who suffered from COVID positivity or has passed away who was placed there by bad policing or just a really botched case by the public defender's office, or the district attorney's office. So I really do hope that this isn't just
this testimony isn't just going through the motions of saying you listened, but you actually take action. People are literally dying on your watch. People are dying because Governor Sisolak and the administration did not take action. We need that action now. We can keep moving forward. There are many organizations who have provided you with lists of people who could get pardoned or have compassionate release, just like the federal government did. And we are really calling on you to take action now. No more people have to die in Governor Sisolak's jails. Thank you.
Thank you, Laura. We'll go to the next public comment. I'm going to call one last time for additional public comment. Is there additional public comment at this time? Hearing no additional calls for public comment, we will close out agenda item number 2, and we will open up agenda item number 3, which is the approval of the minutes. If you called in for public comment, please check to make sure that you are muted if you're going to continue to stay on the phone system to monitor the meeting. We will, as I said, we will have public comment later in this meeting as well. So right now, we will close out agenda item number 2, open agenda item number 3, approval of minutes. The task force will discuss and review the minutes that were provided by staff from the last meeting, offer any amendments or consider a motion and second. Is there any discussion or items for consideration or a motion regarding the minutes that have been provided?
Chair Dave Fogerson, I move approval of the minutes.
Thank you, Chief.
And I'll second.
I think I heard Dagny. Is that right? Sorry, I don't have the right view up. Yep. Okay. Great. So Chief Fogerson has made a motion to approve the minutes. Director Stapleton has made a second. Is there any discussion currently on the minute? Hearing none, all those in favor, please signify by saying aye.
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 Any opposed, vote no. Okay, thank you. We will update those and provide them for all of you. And I'd like to thank staff once again for all of the hard work that goes into preparing those. And I know it takes a lot of time, and they're always timely and available for us at our weekly meetings. So we'll go close out agenda item number 3, and we'll go to agenda item number 4. Because we have a lot of things to discuss today, I'd like for members to just provide their update. And you see the order A, B, C, D through H on the agenda. When one is done, just go to the next, and we'd love to hear your updates. So we'll start with Director Reynolds.
Caleb, thank you very much. This is Terry Reynolds. Real quick report. In the week, 2 weeks of 12/9 through 12/15, we have completed several inspections, and we're really running at a very high compliance rate, 99 to 100%. To date, we have also had 5,600 complaints. I will tell you that looking at the volume of complaints, in the top 10 of those, 7 are in northern Nevada. So basically Reno, Sparks, Carson City, Elko, and Fallon lead those 7 of complaints and compliance complaints. So you can get a breakdown. That site was down last meeting, but came back up the next day. But that site is open now, so you can there's a log of all the complaints on there. So if you want to look at the complaints recently, they're done by period of the time that they were done. So every 2 weeks. And so you can get a full analysis of those. So that's all I have to report. Thank you.
Thank you, Terry. We'll go to Chief Fogerson.
Good morning, everyone. We at Division of Emergency Management, we're working on $137.7 million worth of grant funding to state and local government from the public assistance accounts, from the assistance from FEMA. Right now it is 75% reimbursement. We've asked for a 90% reimbursement to the president because we do meet those criteria, and hopefully we'll hear something back shortly. On the PPE front, the PPE is currently in your agenda packets. We're working on the final push to the charter schools, trying to get that done before Christmas. We're pushing a lot of PPE to the Department of Corrections. We met with them I guess it would be this weekend, and then on Monday, helping them to select some PPE to add to the stock they already have. And in addition to that, we're pushing out the Buy Next Now kits along with Dr. Southard from Health to the Department of Corrections, and we'll get those out to them as soon as we can. And we're pushing a lot more of those Buy Next Now kits out to local government and hopefully to fire EMS agencies in the very near future. That's going out today. So that will help take care of a lot of our issues for the PPE and some of the Buy Next testing front. End of report, pending questions.
Thanks very much, Dave. Appreciate that. And we'll now go to Leslie Mullenkamp regarding CRF dollars and CARES funding.
Thank you. At the Governor's Finance Office, this is actually going to be a very short report today. We do have 13 days left before the Coronavirus Relief Fund is the end of the use of it. So we are working with agencies regarding the final direction on that. Other than that, we haven't received it to this point. Again, things are changing very quickly, but any updates on any funding to replace that. So we're just looking to wind down the last 13 days of the Coronavirus Relief Fund. I'm available for any questions should you have them, but that completes my report.
Thank you so much, Leslie. We'll continue on with Deputy Superintendent Felicia Gonzalez with the Department of Education for an update.
Good morning, Felicia Gonzalez for the record. Nothing here to report new related to schools reopening their school buildings, and hopefully in January we will have additional information as school districts will be convening school board meetings to make decisions moving into January. That concludes my report.
Thank you so much, Deputy Superintendent Gonzalez. We'll now go to Chief Jamie Black with the Gaming Control Board.
Thank you, Chair Cage. Good morning, Jamie Black, Gaming Control Board. For the record, our report is brief this week. Only one new violation since our last report. That brings us to a total of 202. Through December 11th, the board's enforcement division has conducted 1,901 inspections. And just to reiterate, please feel free to reach out to the board and use us as a resource for any questions involving gaming licensees. We are always willing to collaborate. And that's the end of my report.
Thanks, Jamie. I appreciate that. We'll go now to Executive Director Dagny Stapleton with the Nevada Association of Counties.
Thank you so much, Chair Cage. Dagny Stapleton with NACO. I'll also be very brief. As you all know, counties are an important part of the local COVID response, and they're continuing with those efforts. A lot of work around testing has been done. Thank you so much to the state for their partnership. Of course, vaccination distribution, county emergency managers are and emergency responders are a key part of that effort. And so that's been taking up a lot of work the last week and few weeks and months. So, and just thanks to the state for their partnership and their support. That's all.
Thank you. Director Harper.
Thank you, Chair Cage. The cities with enforcement authority over businesses are continuing their inspections, and those without enforcement authorities are continuing to encourage and educate businesses to be in compliance with the governor's guidelines. And all cities are continuing to encourage the use and download of the COVID-19 Trace app. Thank you. End of report.
Thank you very much, sir. And then to Dr. Lake with the Nevada Hospital Association for a quick overview there.
Great, thank you. I'll keep it really quick. We have 1,839 confirmed patients hospitalized at this time, with an additional 136 suspected cases. That represents approximately 35% of all people in the hospital do have COVID. 416 patients with COVID in the ICU at this time. Hospitals are in good status when it comes to medications, ventilators, and PPE, but continue to have some challenges in the areas of staffing and being able to discharge to the subacute facilities. So pretty much the same as the larger report last week. Thank you.
Thank you, Dr. Lake. I'd like to propose that we take a 5-minute break right now and come back at 11:40. Please be prompt. We'll put up a break sign right now. Please make sure your systems are muted. We'll be back in 5 minutes, 11:40, and Megan will call the roll again. Good morning, everyone, and welcome back to today's meeting. It is 11:40. We'll give everybody a quick second to log back on, and we will, since we took a break, we will reestablish quorum. And Megan, if you would please call the roll again and mark me present.
Copy. Richard Whitley. Terry Reynolds.
Here.
I'm here. And this is Richard. I'm here.
Copy. Thank you. Jamie Black.
Here.
Dave Fogerson. Felicia Gonzalez.
I'm here.
Brett Compton.
Present.
Megan Worth Ranson. Here. Chris Lake.
Here.
Dagny Stapleton.
Here.
Wesley Harper.
Here.
Mark Pandori.
Here.
Kyra Morgan.
Here.
Lisa Sherrick.
Here.
Julia Peak.
Here.
Melissa Peak Bullock.
Here.
Melinda Southard.
Here.
Leslie Mollenkamp.
Here.
And for the record, Samantha Laddick.
Here.
You do have a quorum.
Great, thank you very much. Thanks everybody for jumping back on, and we will continue with the agenda as it is written right now. So we'll go now to Kyra Morgan and Julia Peak to go over the current situation report under agenda item number 5.
Thanks, Caleb. I'm just waiting for the PDF.
No problem. We'll get the presentation up shortly.
Director Cage, mine is very short if you'd like me to go while we're waiting for that.
That'd be great. Go ahead.
Okay, so gave a long update last week with a number of changes that we put into place. We're still consistently finding about 20% of our cases through our traditional contact tracing efforts. So want to appreciate all the team's effort on that. The shorter timeline for cases, the shorter interview that I talked about last week for the cases has allowed disease investigators to reach out timelier to more cases. So that has proven successful. We're looking at more ways to automate this so individuals can get their labs much quicker. I'll just note the success of COVID Trace app and ENX. As you know, it launched just recently. That's caused us to get over 230,000 downloads as of last night. We're at 104 cases that have had the app at the time of their diagnosis so far, with 65 related exposures sent as a result of those cases. So again, just want to encourage our residents and visitors to download that app. End of report.
Thank you very much. Appreciate that. We'll go ahead and get Kyra underway, and it looks like the screen is loading now. Go ahead, Kyra.
Great, thank you. For the record, this is Kyra Morgan, State Biostatistician with DHHS. And you can go 2 slides in, I believe. So here we're looking at kind of our standard metrics, averaging over the last 14 days, 2,138 daily cases being diagnosed. For comparison, last week we were reporting 1,872 daily cases being diagnosed, which is a pretty significant jump. Cases over the last 30 days per 100,000 residents are at 2,074. We're also seeing really significant increases to deaths, 22 daily deaths on average over the last 2 weeks. And then testing is pretty consistent, 401 tests per day per 100,000 residents over the last 2 weeks, and a test positivity rate of 20.7%. Daily cases are still consistently double that of what we were seeing during our summer peak. And as I mentioned just previously, we're recording record numbers of deaths on a daily basis. When you look at the bottom trend chart on the left-hand side, the purple one related to cases, you might interpret that as a little bit of a stabilization at the end. It's a little bit too early to conclude that we're approaching any kind of plateau, although I do
kind of share that interpretation of the data. That's really unexpected. We're not quite sure why that's happening. And our best estimate is truly that relates to really having all of our cases related to Thanksgiving exposures in the system at this point. And so really returning to levels pre-holiday, but not necessarily, you know, to a decreasing trend that's significant. It's also important to mention that as Christmas approaches and New Year's approaches, we do anticipate those have significant impact on our cases. And so it's more than likely that we'll see continued increase, even though the trend is starting to show a little bit of stabilization there at the end. Regionally, either Nevada's doing a little bit better or our neighboring states are doing a little bit worse than in our previous meetings. I'm sorry, we progressed a little bit too quickly there, but Arizona is now outpacing Nevada. In previous task force meetings, Nevada was outpacing both Arizona and California. Right now, we're right about on par with where California is in terms of new cases. And again, Arizona has surpassed us. It is now doing a little bit worse regionally. And next slide. Here we're looking at hospitalizations. I think Dr. Lake had one day more recent of data than I have here, so I won't go into details on numbers. Just looking at trends, of course, we still see increases across the state. I think this slide is as of the 15th of December. We had recorded a record number of cases confirmed in the hospital, and then the 13th of December was our record so far for confirmed and suspected combined. We still don't think we've seen the full impact of hospitalization stemming from Thanksgiving at this time, just because it does take a little bit more time from exposure and then diagnosis before someone gets to the severity level that would require hospitalization. So we could still see some hospitalizations trickle in as a result of the Thanksgiving holiday. Next slide. This trend is our test positivity rate, which is at 20.7%. It has been declining since December 8th, which is the first time that we've seen more than a single day decline since September. We believe that this is tied to having accounted for the bulk of testing associated with the Thanksgiving holiday. And while we may return to pre-holiday numbers, it's too early to associate this with a sustained downward trend. 20.7% test positivity remains extremely high, and it continues to imply wide community spread and potentially more undiagnosed cases in the community. Next slide. Here's our table for test turnaround time. We're averaging about 3 days across the state. Again, you can see kind of pockets of where there are larger or shorter times by county and then specific laboratory. And then the next slide shows kind of the distribution by county of how long it takes. So interpretation of this top graph, about 13% of our tests are turning around in 1 day, 36% in 2 days, 27% in 3 days. And so still pretty good turnaround times. And then again, you could see on the graphic highlighted in yellow, kind of the disparity in that range across different counties. Still have some outliers there. Specifically, it looks like Mineral has a little tail, 5% of cases coming in over 10 days, laboratory results, I should say. And then next slide. Jumping right into county tracker, here's the county tracker that we reviewed last week. At that time, Story County was the only county not being flagged for elevated disease transmission. And then just a reminder that these data do include prison cases. And then the next slide compares that to data that were produced Monday. Here we saw Eureka for a very short period of time kind of drop out of the criteria for elevated disease transmission. Since this data pull, however, if you're looking at our state dashboard, which is updated on a daily basis, you'll notice that Eureka has since come right back into elevated transmission status with a high positivity rate once again. And then, when you just look at these numbers compared to the previous slide, you'll notice almost across the board, there's a couple counties with exception, but almost across the board, we're still seeing movement in the wrong direction. So test positivity rates are still increasing, and then case rates in the last 30 days are still increasing. Next slide. Here we compare the county tracker criteria to include or exclude our prisoner inmate population. Again, the logic behind this is fairly standard in public health. We often segregate out our prisoner inmate population when we talk about disease spread, just because when we think of transmission, that isn't a population that is frequenting the same places. Their exposures are obviously very limited. And so when we talk about community transmission, it's fairly standardized to consider that population separately. Here in the left-hand table, similarly to the last couple of weeks, you can see our criteria with the prison populations included in our county numbers, and then table in the middle of the screen shows that if we exclude those prison cases from our general population, we still have elevated disease transmission. In fact, there's no county that when we exclude the prisoner population actually comes out of an elevated transmission status. There are some significant differences just around the specifics of the numbers of how bad it is, how many cases there are. But in general, when we talk about elevated disease transmission, again, not a huge impact on where counties fall. And then the table on the right just shows the exact difference of that change. And then I won't go into details on the next 3 slides, but they are there for your reference. They just show the testing cases and test positivity rate trended over time so that we could see kind of where we've been throughout the pandemic. Again, they continue to kind of become denser as far as the red coloring, which indicates higher numbers in general. And then with that, I'll take any questions if there are any.
Thank you both, Julia and Kyra, for your work in putting those together. This is the top line information, the top line takeaway that I'm seeing from that right now is, while we are experiencing something that looks like stabilization or potential towards trend, we're a stabilization trend or even a downward trend in some parts of the state. We're still highly elevated, and we could very easily start trending back upwards here in the near term as well. Is that a fair sort of snapshot?
Yeah, I think that's absolutely correct. And one thing I didn't add, but is important also, when we look at test positivity, I mean, that's the measure where we see what could be interpreted as the most significant change in trend over the last couple of weeks. Again, we haven't seen a decline since September, and we've seen a consistent decline since the 8th. I just want to point out that number is extremely high, and it's a percentage of tests essentially coming back positive. And so, it kind of has a natural glass ceiling. It naturally is going to hit a maximum and be pretty hard to be higher than a certain number. So we actually have been anticipating test positivity has to start coming down because it just can't keep going up, especially with the volume of tests we're doing in the state. And so that's why we really want people to exercise caution when interpreting that. I mean, we obviously really hope that it's a significant downward trend and we're going to sustain that, but it's too early to tell.
Great, thank you. Other discussion from members of the task force? Okay, hearing none, I appreciate that. Dr. Pandori, I know you're next on the agenda. If it's okay with you, I'd like to switch agenda items 6 and 7 so we can go ahead and hear from our colleagues at the Nevada System of Higher Education. I see the UNLV, okay, you see UNLV and UNR both on here. So what I'd like to do right now is, Jackie, if there's a presentation here or any comments, thank you very much. So we'll turn it over to University of Nevada, Reno and University of Nevada, Las Vegas.
Thank you very much. And on behalf of UNLV and the Nevada System of Higher Education, as well as our colleagues at the University of Nevada, thank you very much. Sitting through the public comment has provided great perspective, and we recognize you have an incredible heavy lift. And so we're just one tiny small part, but what we wanted to do was to share with you how we are mitigating our efforts in intercollegiate athletics. Our highest priority is safeguarding the health and safety of our student athletes. We've worked collaboratively throughout this pandemic with our colleagues at the University of Nevada. And with that, I'm going to turn it over to my colleague, Athletic Director Doug Knuth, to go over how the current protocol within the Mountain West Conference, as well as the NCAA and the development of the same. And then my colleague, Sarah Wattenberg, will review our positivity rates, and then I'll end our very brief presentation because we recognize that your time is incredibly valuable. I'll end our presentation going over when we have a positive, this is what we do.
Thanks, Desiree. Mr. Cage and members of the board, thank you for your time. We really appreciate it. This is an amazing opportunity for us to present to you. I am not a doctor and I will not pretend to be one, but I do want to thank our doctors. We've had incredible advice and support from our friends in medical world. And frankly, we could not have done what we're going to present to you today without their incredible support and hours of work from a handful of folks at both universities that work with our teams, hands-on with our teams. And I want to call them out if I can by name, just so you know who they are. And from the University of Nevada, Las Vegas, we have two amazing docs that have been working with us. Dr. Brian Labus is an assistant professor in public health at the University of Nevada, Las Vegas, and amazing support for Desiree and her staff, and does a great job. And he's met with Mountain West Conference a few times with us as well. And then Dr. Wade Gall is a family and community medicine, sports medicine specialist at the University of Nevada, Las Vegas. Amazing guidance, support, and as I said, friendship, really, these folks. And then here at our campus, University of Nevada, Reno, our two team physicians, Dr. Tony Eastlis and Dr. Mark Stovak. And these folks, as well as Dr. Gall, are on the Mountain West Conference Medical Advisory Board. And it's made up of, as you would imagine, of the team physicians or family medicine specialists from each school in the Mountain West Conference. And these folks have come together weekly over the last months and months to develop our protocols, to talk about how it's going, to provide feedback, to make sure that we're all marching down a safe path for our student athletes, our coaches, and our staff. And then lastly, I'll say Dr. Mark Stovak and our staff here at the university is actually on the NCAA Medical Advisory Committee. And that's the highest level medical advisory committee. He is among a number of doctors from around the country that are advising the chief medical officer for the NCAA as to how everyone in the country should be operating. And so it's fantastic for us in our state here to have a person that's on that group speaking at the highest levels nationally and developing protocol nationally. So I share all that because it's important for this group to understand that we are getting great medical advice, not only locally, but even on the national level. We are on the forefront of the latest information and making the best decisions for the health and wellness of our student athletes, coaches, and staff. And so just briefly, the NCAA Medical Advisor Group led by Dr. Brian Hainline, they've developed what they call re-socialization plans for all of our athletes and all of our teams. And those recommendations follow the CDC recommendations. So they're tied, they're in lockstep. Everything we are doing is following CDC recommendations, and it trickles down from the NCAA down to our conference, which is the Mountain West Conference. And as I mentioned, we all have our team doctors involved in the medical advisory group for the Mountain West Conference. And those protocols are developed with different levels of risk, right, associated with different sports. And we have some of our sports are considered higher contact or higher risk sport. As you can imagine, a sport like football is a high risk sport. I believe a sport like volleyball is a high risk sport. Swimming or cross country are less risk sports, less contact among the athletes. So we developed these protocols to follow the guidance of the CDC and the NCAA and obviously the Mountain West Conference. So ultimately, we are testing our high-risk sports, football throughout this fall, men's and women's basketball, which are currently practicing, competing, considered high-risk sports. We're testing those student athletes and coaches and staff 3 times a week. And, the results have been very, very good. We think throughout the duration, going all the way back to June when we started the testing protocols. And I think throughout this presentation, you'll see we've done a very, very good job in testing and controlling anytime we have a positive test, controlling it, isolating it, separating it so that we don't have spread among our team, our staff, and our department. So I'll stop there and turn it over to look at the more of the details and numbers behind it. But again, thank you all for your service. Thank you all for what you're doing for our state. We greatly appreciate it.
Thank you. Jackie, if you wouldn't mind progressing a slide or two, and then the next one as well. So as Desiree mentioned, health and safety has been our number one priority. And as Doug has mentioned, we've followed a lot of guidelines. So the next slide, you all should recognize, as I pulled this off of the Southern Nevada Health District website on Wednesday evening as we were putting this together, and having Dr. Brian Labus as a colleague, I learned early on in this process that we wanted to make sure we were tracking on our positivity rate, and that the World Health Organization had set 5% as the goal to get the spread of this virus under control. So if you will progress to the next slide, please. This shows UNLV in red and UNR in blue as appropriately colored. This has been our testing positivity rate per week since June when we first started this. And you'll see that UNLV athletics had a spike from some of our teams who did not follow our mitigation protocols, because after all, we are hinging on the social lives of 18 to 22-year-olds. So our one small blip, we were able to identify right away, and we shut down right away for 2 weeks. And so you will see that for the entire semester, we have stayed below, with the exception of the one time, below 5%, well below 5%. So I think, and you'll see on the next slide, our overall positivity rate, average positivity rate for UNR is at 1.2%, and for UNLV at 1.3%. So I will turn it over to Desiree.
Thank you very much, Sarah. And Sarah is our Director of Sport Performance. She oversees the holistic sports medicine needs of our student athletes and has worked collaboratively with the University of Nevada's Director of Sports Performance as well in preparing this presentation. Education has also been a cornerstone of our protocol and process. We've done a combined over 50 hours of education for our students, and that's combined with the University of Nevada and at UNLV. Education for our student athletes, for our coaches, and for our staff. When we have an outbreak, we cease activities immediately. Case in point, our head men's basketball coach tested positive on Monday, and we ceased basketball activities for the next 2 weeks. So we take this very, very seriously. We are working very collaboratively, and we're listening to the experts. When we have a positive case, for our student athletes, we have a 5-step plan. The first step, we isolate immediately. The second, and we find alternate quarters for them. The second step, we work in, and this is actually in conjunction with the first step, we work with Brian Labus and our sports medicine folks in contact tracing and do the immediate notification. The third step is we do the physical checks with our team doctor and sports medicine personnel. The fourth check, because our student athletes are in isolation, we have food delivered because our student athletes need to eat while they're in isolation or in quarantine. And then the fifth step is our sports medicine staff checks in via Zoom every day with every student athlete while they're in quarantine and isolation for that health and wellness screening. In order to enter any of our buildings, there's a temperature check. There is a whole process in place. And so you don't enter any athletic facilities without having a wristband. The wristband signifies that you've had your temperature checked, you've gone through the screening questions, and that you've been in the testing protocol. So with that, again, our sincere thanks to everyone on this call. We can't even begin to imagine the depth and breadth of the work and scope that you are working with, and a sincere thanks on behalf of our athletic departments.
Well, we'd like to thank you both for thank you all three for the presentation here today and for taking the time as well. And, we've reached out to a number of entities within the Nevada system of higher education, as you know, to make sure that overviews of your programs are being heard, and we can have a direct interaction and an opportunity to talk. with one another. We appreciate you doing so again today regarding these two sports programs within the system. I'd like to see if there are any members of the task force who have any questions, comments, or anything related to this presentation that we have heard from our two athletic directors today.
Caleb, thank you. This is Terry Reynolds. I want to make a comment that we really appreciate the cooperation we've had from the universities. They've been outstanding to work with and really willing to share information and work with us. So it's been a real pleasure, and I want to thank both athletic directors because they have been outstanding in terms of their cooperation. So with that, in addition to that, I wanted to ask, is the guidelines, the standards for the NCAA sports all generally the same, or does it vary by conference?
The NCAA first of all, thank you, Mr. Reynolds, and thank you very much for being a resource. And we apologize if we have worn you out and probably over-emailed you. but again, thank you very much for your patience with us. So the NCAA sets forth rules, and then those rules are localized within each respective conference. So some, for example, the decision to play or not to play. You saw conferences make contrary decisions based upon their locales. Some locales where they had large outbreaks have different rules that were promulgated. We do follow the NCAA rules, and then ours become more strict.
Okay, thank you. That's all I have, Caleb.
Thank you, Director. Other questions, comments from members of the task force for our presenters here? Great, thank you very much. I really appreciate you all taking time to be here and to present for us today. And we look forward to continued partnership, and thanks for all you do. Thank you.
Thank you, sir. Thank you all.
At this time, I'd like to close out agenda item number 7 and go back to agenda item number 6, which is the update on COVID-19 response from the Nevada State Public Health Lab. And I know that there is a agenda item number 6, UNRCT value COVID-19 lab report presentation for this. So Dr. Pandori, if you're ready to go, and Jackie, if you could put that up for us, that would be great. Dr. Pandori.
Thank you, Chairman Cage. This is Mark Pandori, the director of the Nevada State Public Health Laboratory, and I'm grateful for the opportunity to address a topic that has come up in public comment quite a lot. And I know I've received quite a lot of personal email about the topic, but also my peers, that is the other lab directors in the other 49 states, have also been receiving a lot of inquiry about this topic. It's a very specific topic and it gets kind of down into the weeds, but I think what I'm going to try to do here today is bring us all to the same level of an understanding about it. When we perform lab tests for SARS-CoV-2, we get what is perceived as a binary result of positive or negative, but there's a numerical value that's associated with that result, and it's attracted quite a lot of attention, and rightfully so. What I'm going to do in the next several slides, and I hope to be brief about it, and also try to keep this rather detailed scientific topic at a reasonably understandable level. But what I want to do is talk about what these CT, as we call them, these quantitative values mean. We call them CT values, and whether or not there's any utility to them. I wanted also just to say, though, that I appreciate the opportunity to talk about this topic genuinely from a scientific perspective, because this is a scientific discourse that we're about to have. There's no politics here involved. We actually get to talk about the meaning of this quantitative value that we generate with a lab test. And these questions that are coming up about CT values have real merit and scientific validity. So again, I'm really glad to do this because it's all grounded in scientific observation. I just want to make sure that my tone here is not at all combative, but instructive, and that I'm not taking a contrarian view. All we want to do is have an understanding of this so that we know what the hurdles are, because we may use these values someday, but we need to get past certain hurdles and we need to face certain considerations. Because I think we have to face the fact that as long as this virus is in our community, we need some sort of public health clearance process to classify people as infectious or not. So if I could have the next slide, please. First, want to just get us on the ground of what we're talking about when we talk about CT values. CT value was associated with a PCR lab test result. PCR is the preeminent lab test throughout the world for the detection of SARS-CoV-2. What you're doing with PCR is you're detecting the genome of the virus, just like us or our pet dogs or our pet lizards. The virus has a genome. It's made out of a molecule called RNA. With PCR, we can take DNA molecules and amplify them, and we can do that very well. So after a brief conversion of RNA to DNA with a sample from an individual, we can apply PCR amplification in steps. These steps we call cycles. And with every cycle, we do a thermal temperature. We have equipment that precisely changes temperatures of the chemical reaction. And every cycle results in a doubling, theoretically, of the amount of target RNA, rather DNA, that's present. It's that amplification, those cycles of amplification, that give the test of PCR its powerful sensitivity. That is, its ability to detect tiny amounts of things. May I have the next slide, please? As the amplification process is occurring in cycles in the lab during PCR, the detection of the products of those cycles occurs. They give off light. We call it fluorescent light, and it's measurable. There's a number we can attach to that. So what we do is we look at every cycle, and if the amount of light that's been generated passes a certain value we call a threshold, then we call that specimen positive. And where the amount of light crossed that threshold is a cycle, we call that CT, or cycle threshold. That is, at what cycle did the amount of amplification pass that threshold? And then it allows us to call specimens positive if they pass that threshold of light, of fluorescent light measured, or negative if it does not. May I have the next slide, please? So the thing about a CT value is it's a little reverse or counterintuitive. A very high CT value correlates with a low amount of viral target. A low CT value correlates with a very large amount of target. It's best to think of a CT value that we generate as an amount of effort. If there's a tiny amount of virus present in a sample or genome of the virus, it takes a lot of cycles of amplification for the test to pass that detection threshold. If there's a whole lot of that present, it doesn't take many cycles of amplification to trigger a positive result. So I usually try to describe CT values in that inverse relationship as kind of a score of effort that the test has to make in order to generate positivity. Can I have the next slide, please? The overall process of PCR is important to understand when we dive into determining what the hurdles are that remain for us to use CT values. A specimen, a swab is taken from an individual. That swab may or may not have virus on it. We actually have to take that swab and all the liquid that it sits in, and we do a chemical process to pull out all of the RNA genomes that might be present, if any, if it is in fact a positive specimen. We then do a chemical step to convert all that RNA into DNA, and then we apply PCR amplification, which is what I just described. We then assess to see whether or not amplification resulted in enough fluorescent light to see whether it passes a threshold, and if so, when it passes that threshold, that is a CT value. Next slide. So what we have learned, and this is not really a surprise to virologists or laboratory diagnostic scientists, is that CT value does correlate with how much virus is in that sample, and therefore it correlates with how readily virus can be grown out of that sample. So all I'm showing on this slide, it isn't intended to be read, is that there's actually a number of peer-reviewed publications that describe lab experiments where people have shown that when it takes a lot of effort of PCR to get a positive result out of a specimen, it's not only reflective of a small number of virus particles, but it's also in these experiments reflective of the idea that it's very hard to call that specimen very infectious, okay? And the way that these experiments have proven that is to take those samples and not only do PCR on them, lab testing that is, but to do another kind of lab test, which is called a culture. And I'm gonna have a next slide on that because culture is a very interesting lab test. And it came up in public comment today as well. So could I have the last slide one more for just one more second? I wanted to emphasize, again, in the interest of absolute scientific fairness, not only has this been observed in labs, but the CDC has seen it, and some unpublished data is talked very clearly about these CT value correlation with infectivity, or at least the ability to infect cell culture. And I myself have actually gone into our own biosafety level 3 facility and done experiments to see if there is a certain cutoff. And I have found myself that these are true observations. Can I have the next slide? But what is it that what all of these studies that we're homing in on, and that many have astutely in our own public pointed out, what is it saying? Sorry, the intercom is going off here. What those experiments are saying is that those specimens that have high CT value aren't culturable. What is culture? Culture is another lab test that we can use to ascertain for the presence or absence of an infectious agent. For viruses, we do that with mammalian cells that we grow in a dish. Okay, it's a dish with some red juice in it that provides food to the cells. We grow these cells we're capable of using these cells as targets. So if there's a virus in a swab sample and we put that sample in the dish with the cells, the virus will infect the cells and then produce more virus. So that's a lab test to detect viable functional virus. The cells that we use in those experiments have to be cancerous. That is, they're immortal. The ones that we use in most labs, almost virtually all labs use to do culture for SARS-CoV-2, are cancer cells that came out of an African green monkey in the year 1962. They've been propagated now for 58 years in labs here at UNR and labs throughout the world. They serve as a really functional reservoir for the virus to grow in. And it's these cells that make up the vast majority of studies that we showed on the previous slide. So let's be clear. The studies are showing that specimens that are positive on PCR with high CT values can't be grown in these cells. May I have the next slide, please? I thought you might like to see a picture of what these cells actually look like through the microscope. And what's being stated here in these experiments is that when specimens have a very high CT value and you look through a microscope, you don't see infected cells or the savage amount of cell death that you see like in part B of that bottom slide, which is what it looks like when we put low CT value specimens in culture and they destroy cells as they grow in them. So the question that comes up often is, well, gee, maybe PCR goes too far. And it's a very legitimate question, as I've stated on numerous occasions now. One thing that I can say immediately, because one of the questions that comes in a lot is how many cycles of PCR are you running? Because maybe you're running too far and you're finding positive specimens that can't infect these cells. No lab at Southern Nevada or here at the state lab or at UMC runs any laboratory test that goes beyond 40 cycles of amplification. I'm unaware of any marketed test that does so, because eventually we all know in diagnostic science, when you start going beyond 40 cycles, you're amplifying dead junk. And we've known that for a long time. But rest assured, here in Nevada, no lab here that's operating in Nevada is operating beyond 40 cycles. Our cutoff is 39.99. May I have the next slide, please? So now what I wanted to do just shortly for the remainder of the talk is give 7 considerations that need to be made, because while I've now made a case and said there's plenty of evidence, even my own eyes have seen it, that these CT values can correlate with an infectiousness in African green monkey kidney cells, what we need to do now is look at the big picture and say, okay, what are the hurdles and what are the considerations that remain for us for not using these CT values yet? May I have the next slide, please? Number 1, there's a lot of different assays out there that people do use to do PCR. We've already switched our test 4 times here at the State Public Health Lab in search of the best test. I thought you'd like to see some raw data to look at real CT values out of the wild in some experiments we've done here in the lab, and to show you that for some samples, it's actually very readily apparent that we get differences of 2 or greater in CT value. This is comparing a very, very popular commercially available PCR called the Thermo Fisher TaqPath to the CDC assay, which was the first assay we ran here at the State Public Health Lab and actually still do run on some occasions. What this is showing you is that for the N gene, which is detected by the Thermo Fisher assay, and the N genes that are detected here by the CDC, that here in several instances, about 40% of instances between the two assays, we see a CT value of 2 or greater, which corresponds to at least a 4-fold difference in viral load on that swab. So this is the same specimens on each row, okay? Each row is showing a specimen and generating the results from 2 different assays. So in order to use CT values, we would need to establish CT value standards. But would we be able to do that if different assays achieve different CT values on the same specimens? For example, if we set a cutoff of 33 and one lab was running Thermo Fisher and one lab was running CDC, you could easily get 32 or 34. If you called that 30, you wouldn't want to call that 32 uninfectious. A mistake here could be rather significant. So we need to find a way to standardize across assays. And I'm only showing you 2. There's assays where you can very easily get a 10 difference in CT value if you use something like an Abbott-based PCR. Can I have the next slide, please? Not only does the PCR method show the difference, but one of the reasons I showed you that grand process, the whole process overview on an earlier slide, is that the way that you extract the RNA or DNA out of these specimens also affects the CT value on the back end. So here I've, with arrows, shown you raw data also from the State Public Health Lab, where we've looked at 3 different extraction kits. We actually have about 5 extraction methods here in the lab so that we can always stay in the testing business. But what we see is significant differences. Again, very easy to find CT value differences of 2 or greater just by how the specimens were extracted. So again, if we wanted to use CT values, it would be very difficult to set a standard because everybody would have to use the same test and everybody would have to use the same extraction kits. But we can't do that because there's no way that the supplies, we need diversification in that regard because there's simply not enough supplies from the vendors for labs to test in that manner. Can I have the next slide, please? So the next question is, I showed you that those papers that support the CT value correlates with infectivity are all dependent on using cell culture. Cell culture, again, is cells that are cancerous. Many of them have been growing for 50 or 60 years now in the world in different labs. Is that a proper surrogate for true infectivity? The answer is we don't know. For HIV, we can infect primary cells that we pull out of human beings that'll grow in the lab for a short time, or we can infect these cancerous cell lines, and we see vast differences in how infectious the viruses are to those 2 systems. So is a cancer cell line from an African green monkey who had kidney cancer in 1962 a proper surrogate for actual infectivity? I'll merit to your attention that the virus has been growing and evolving in real life systems, not cancer cells, for thousands and thousands of years in mammals. So if anything, a virus that shows a certain amount of infectivity in a synthetic system like a dish like that might actually be far more infectious if it were presented to an actual person, which is how the virus has actually been evolving for thousands of years. Next slide, please. The other thing to consider is that the infectiousness of the virus that's in the nose and goes onto the swab at that time of collection is the true, at that moment, the true infectivity exists on that particle. But that swab goes and sits somewhere for a while, could be 1 to 3 days before it reaches the laboratory. It will sit in a car, it'll get driven, it'll then go into a lab refrigerator, will sit longer. So one of the things that may be occurring during that time, and we do see this with HIV as well, is that infectivity will decrease as it waits to get in line for testing, and even over a 24 to 72 hour period. So the CT value that's generated on a specimen that's gone through all of that process may not be truly representative of the infectiousness of a particle that's actually coming out of somebody's nose, because of the way that those two things would have been treated very differently. Next slide, please. The other thing to consider, and this is less of a hurdle that we have to get over than something that I want people to consider, because there's a lot of misinformation out there. In authoring a paper from our lab where we were looking at CT values here at the State Public Health Lab and looking at outcomes, one of the things we noticed was that over a very large sample, very early, we were doing the CDC PCR, we looked at a very large sample of positive specimens and found that the average CT value was 27.55 with a standard deviation of 6.11. When you look at the data overall, about 84% of that means that about 84% of everything that has tested positive at the state lab has a CT value of 33.66 or below. What does that mean? If the CDC is drawing the line at about 33 for their assay, that would say that 84% of the positive specimens that we've tested would have been considered infectious in any regard, which is to say that a minority of specimens would even fall into the category of being, let's say, not a public health threat based on CT value. So I throw this slide in there because there are, some theories out there that say that the whole pandemic is caused because PCR is too sensitive. And I'd like the data to disabuse us of that notion. May I have the next slide, please? Another consideration that we have to be very careful of with CT value is that viral load is just a measure at a moment in time. If we look at a curve, this picture here shows very roughly what happens when somebody's infected with SARS-CoV-2. There's an exposure, viral load will increase to a peak, and then during recovery, viral load will decrease with a period of infectiousness and symptoms in that interim. But may I have the next slide, please? Here, what I wanted to show you was that the CT value or viral load, as they correlate, were on the y-axis of this. That's the one going vertical up and down. The same CT value could mean two different things biologically and physiologically. That is, it certainly could mean that, as many people say, you're beyond the infectious period, and that CT value is representing recovery and not a public health threat. However, that high CT value or low viral load could easily be the upswing of the infection. If we misclassified that, if we saw a high CT value and said, you're fine, you're recovering, when in fact that person was on the upswing, that would be catastrophic, because you would be saying to somebody, you're in the clear, when in fact they're getting ready to become more infectious than they will ever be in the course of their disease. We actually see this with HIV. When we're relying exclusively on antibody testing for HIV, we were missing people who were recently infected and were going on to infect other individuals. Not only that, but we were telling them they were negative because of this misuse or misclassification based on lab data that was not being utilized properly. May I have the next slide, please? The last point is that the published literature actually does not agree on this quite yet. In fact, this publication, Journal of Infection, is very interesting. It showed an ability to get a culturable virus out of CT values 36 and greater. And what their findings were that there's a nuance to this, that although you could get any CT value out of a specimen, but what determines whether it's infectious or not is how close that specimen was taken to the development of the initiation of symptoms. So what this means is that we really need to we have to foster a much more complex understanding of how CT values can be used. And I'll take the last slide. So where are we going to go and what's going to happen? The truth is, as I stated in my first several slides, and I'll say it again, this is an argument, a great scientific debate, because it's grounded in truth and merit. And we need tests that ascertain whether someone's infectious or not. Nobody will disagree with that. So how do we move forward? Well, if there's some way to create a standardization between different brands of lab tests and different brands of extraction methods, we can ablate that sort of fog that occurs or differentials that occur from assay to assay. And that would require somebody like the FDA to help us generate standards so that we can do viral load testing, very similar to what we do for HIV. Another exciting possibility is that antigen tests might correlate better with infectivity than PCR tests. there's a possibility that the detection of antigen and positivity for antigen may correlate better with culturability or infectivity. And if that's the case, it's a bonanza for public health and medical science, because what we'll be able to do is not only use a cheaper test and a more accurate test, but something that we can apply very quickly to get people back to work or school or whatever they need to do. Another possibility would be, instead of standardizing all the assays into one standard curve somehow, is that we might ask that for future development of assays, that companies determine those cutoffs on their own somehow and have per cutoff assays. We did have something like this in diagnostics for HCV for a while, and it might be possible, that is hepatitis C virus, and we might be able to do that here with SARS-CoV-2. Last point, whatever happens, you can't expect a lab to suddenly start using CT values like instantaneously, because that would have to get approval from the FDA. And right now, while the FDA allows the printing of a CT value on a lab report, they do not support its use for any medical or public health action or effort. I want to tell everyone how much I appreciate the opportunity to address a topic which has come up very frequently, and it merits attention. And I'm actually proud, and I commend our state for and our citizens for paying such attention to it, and for providing me with an opportunity to have this discourse. Thank you.
Thank you, Dr. Pandori. I have some questions. But first, I'd like to just say thank you to you. I am not a scientist, and much of this is very difficult to understand. And I just want to say I think you have a knack for making things very understandable and explain it at a level that I think is broadly accessible as well. So I just want to express my appreciation for that. I know that others would like to ask questions. In fact, I'll hold my question to see if any others would like to ask any questions from your excellent presentation. Anyone from the task?
Caleb, this is Terry Reynolds. I wanted to ask Dr. Pandori, for example, one of our employees, when they're exposed to somebody who's positive, we've actually told them to wait 4 to 5 days to get a test after that exposure. Is that good advice in terms of when they should be testing? Our concern was that they would go run out immediately and get a test, and they may not test positive at that time, may not be a valid test.
It's superb advice, sir, because we think it takes there's what we call an eclipse. After exposure, it takes about 5 days for the virus to get to the point where it would be coming out of an individual and could be detected in a lab test. In some cases, it can be a little longer. There was a really interesting study done very early on in the pandemic in Singapore, where as soon as people had anything, even a fever, they started PCR testing every day. And what they found was it's possible to test too early, just as you're hypothesizing correctly. And that is that some people, when they just had a little bit of a fever or body ache, they were still negative, and it took 2 or 3 days for them even then to become positive on a PCR test. We've seen that quite a lot in HIV, where people get very nervous after an exposure, but it might take up to 10 days or 20 days to become positive on those tests. For this, I think it's very wise to offer that 5-day buffer, because if you misclassify because you test too early, there's a potential public health outcome of that that's very undesirable.
Thank you.
Other questions from the task force members?
Hey, this is Felicia Gonzalez.
Yeah, go ahead.
Dr. Pandori, thank you so much for that amazing presentation. At the very end, you mentioned that one of the ways forward is to utilize antigen tests as a means as clearance. Could you expand upon that a little bit, especially related to how we could utilize it in education?
Yeah, the disclaimer is that no August body, the FDA, no governmental body is yet recommending this. I'm saying there's evidence to support the following, and that is that an antigen test is measuring, while the PCR test is measuring the genome of the virus, that core part of the virus, The antigen test measures a chunk that's sitting on the outside, and it uses a different kind of chemistry to do that. And as it goes, it seems there's some data now to support that when somebody is positive for that chunk of protein that's on the outside of the virus, when they're positive on that antigen test, that correlates better with whether or not that person is, that virus that's detectable is infectious. Does that make sense? So you can certainly be positive on a PCR, but have no infectious virus coming out of you, at least by the way we measure it. But we think that correlation between infectivity and positivity is better with antigen tests in culture rather than PCR tests in culture. Does that help at all?
Thank you.
Additional questions from members of the task force? If I could, you said on your, I believe it was your second to last slide, you mentioned one of the ways forward, I think, was to have per assay cutoffs between the different kinds of tests. And I apologize, I just didn't catch what you were saying at all. If you could you explain that for me?
Yeah, it might be the least likely way forward because this would cost companies a lot of money. But what it would do is to say that it's just a suggestion that if I'm saying that, let's say 4 companies have 4 different lab tests, and if I take one specimen and I run it on those 4 lab tests, I'm going to get CT value of 30, 31, 32, and 33, okay? Just because the tests are different. And so the correlation for those tests' CT values and infectious virus is going to be different for each test. On one test, a CT of 30 might correlate with infectious virus. On another test, that same amount of virus might score a 33. So we would have to say on a per assay basis that the CT cutoff should be different. Because what we do know for sure is we can take the same amount of virus and throw it at 2 different tests here in our lab and get 2 different CT values about half the time. So if we had cutoffs that were based on an individual assay rather than somehow trying to unify all this, we might be able to get there that way. But it would require companies to ascertain that for their assay before it went live. Does that make sense?
Yeah, that helps a lot. I appreciate that. Want to make sure other members of the task force have an opportunity to ask questions as well. Any others? Okay, I really appreciate the dialogue, and Dr. Pandori, I know this is your life and has been for some decades now, and it's really great to have updates from you to really better understand all of this. I think from an emergency management standpoint, we think about logistics, we think about getting supply kits, we think about getting more testing capability, more throughput, all of those things, and understanding and really having the dialogue around this, these scientific specific aspects of this is really critical. So very glad you're a part of this task force, very glad you're in the position you're in for the state, and just want to say thank you again for your comments as well. So appreciate it.
Thank you very much. And my final statement is I want to encourage further public dialogue, and I'm always available by phone or email to continue the dialogues, which I've had outside of this meeting as well on this topic or any other testing topic, because I think everybody deserves the same level of understanding about these things. Thank you.
Thank you. I appreciate that. With that, I'd like to go to the next agenda item number 8, which is the update on COVID-19 response within the Nevada Department of Corrections. And I know we have Director Daniels here from the Department of Corrections. And so you and your team, I'd like to turn it over to you, sir, and we'll hear your update.
Good morning. My name is Charles Daniels, Director of the Nevada Department of Corrections. I thank the COVID-19 Task Force for the opportunity to present the efforts our agency has taken in response to COVID-19. As of December 16th, 2020, NDOC has an offender population of 11,191 inmates. This number excludes pending transfers from local jurisdictions. In February, agency leadership commenced strategy discussions regarding coronavirus. NDOC's firewall strategies were initially established on March 16th, 2020, and have been continuously modified based on recommendations from the Centers for Disease Control, the World Health Organization, and the state of Nevada, a medical director, to the extent practicable. NDOC established protocols based on a trigger event to initiate testing of the offender population. This protocol is unique to each facility and institution, which included establishment of sanitation and isolation protocols. Inmate briefings, known as town halls, occur at each location every Tuesday and Friday. NDOC limited staff contact with offenders. For example, inmate workers' schedules were changed to have less contact with staff. Hand sanitizer was made available for all offenders upon request. Masks have been issued to all offenders and may be swapped out at the inmate's request. Testing of the offender population started in June and continues. Testing intervals have changed over time. NDOC has adopted a when in doubt, keep it out mantra early in the fight against COVID-19. During the daily screenings of all staff, anyone who presents with COVID-19 related symptoms are screened out and denied entry into the institution or facility.
Director Daniels?
Yes.
I apologize for interrupting you, sir. Can you tell us what slide you're on so we can make sure we're updating that for the public?
Thank you for your question. I am actually on my opening comments, and then I'll transition into the presentation.
I appreciate you explaining that. Thank you, sir.
All right, thank you. Following NDOC's trigger event in June, offender testing began on a rotational basis. Initially, staff were tested every 2 weeks, inmates every 3 months. Starting December 8th, weekly testing began. This protocol was put into place to mitigate exposure. Despite facing challenges of acquiring hand sanitizer, thermometers, and other basic recommended items, NDOC was able to use prison industries to manufacture hand sanitizer for agency-wide distribution to all staff and offenders. Once face masks became a requirement, the agency was able to further utilize prison industries to manufacture face masks. Each NDOC employee was provided with 2 face masks, and offenders were provided with 2 face masks. NDOC continues to modify operations to include feeding schedules, isolation and quarantine unit establishment, out of cell time, and others. So I'm going to go ahead and transition now into the presentation. So we're on slide 1, so if you don't mind, we'll just go right on into slide number 2. Thank you.
Again. She's gonna have to click. Advance again. Okay. Yeah.
Okay. So we're going to cover a lot of mileage. So here's the overview as we move forward. We're going to have a discussion on the impacts of COVID-19, a little more of the background. We're going to discuss data as well as definitions. We're going to explain the transition of our protocols from the first wave, which we consider March through August, and then wave 2, which was September to date. We're also going to have a brief discussion on quarantine, isolation, testing, personal protection equipment, and institution operations. Next slide, please. Now, I do want to point out as we move forward that there's a little bit more on this slide. I do want to point out that I have several of my staff with me because then they can elaborate on some specifics. Here with me, here in Las Vegas, I have Deputy Director of Prison Industries, which his name is William Kawenga. I also have my medical director, Dr. Michael Manev. And we will also have up in the Carson City area, I'll have my deputy director of operations, who is Brian Williams. And I have others as we need them. So let me start with this slide. As you can see, we have a column for both staff and for of the offenders. This data is current as of December 15th. For those of you that follow the data, you know not everything comes in at the same time, so we had to pick a date and we had the latest information. So from a staff perspective, we have 205, this cumulative number, Dr. Manev, or this current?
It's current.
Okay, the current is 205. We have 179 on quarantine, and we have 239 staff members on isolation. To date, right now we have admitted to hospital 7. We've had 2 staff members, unfortunately, died under COVID-related symptoms, and then we don't currently have anyone pending a test that could turn up as COVID-related. As it relates to the offender population, we currently have 1,624 inmates testing as positive. We also have 2,971 currently on quarantine. We also have isolation, 1,624 in isolation. Currently, we have 22 inmates that are admitted to the hospital. In total, we've had related to COVID-19 deaths, 8. And then we don't have any inmates in the hospital or recently expired that are pending a COVID-19 test. Next slide, please. So I'm going to transition to what we call a little bit more background, but I'm going to allow some of the other folks to elaborate on it. So what we did is we implemented our firewall protocols. And I will let Deputy Director Williams chime in on this. Can you hear us, Deputy Director Williams?
Good evening, everyone. Deputy Director Williams for the record. So in implementing this protocol, we were doing our best to keep the virus out. So the first thing we looked at is those that are coming into our facility. So we suspended visitation and all NDOC employees and non-NDOC employees, which consisted of Clark County School District, other school districts, Carson City, that normally come into our facilities to provide services. We then quickly began doing health screening of all employees, doing temperature checks to ensure that their temperatures were at normal levels. We adopted the slogan, when in doubt, we're going to keep you out. So if we had any staff who showed symptoms or had any type of temperature, raised temperature, we would definitely contact our medical department at the facility or Dr. Manev to discuss with them if it's okay to let them in. And then in most cases, they were not allowed in and they were asked to isolate. Sanitation protocols, cleaning throughout the facility, having inmates go wipe down door handles, windows, anything that was touched by a human. We conducted testing of our vulnerable population, which consisted of our high-risk pregnancy, chemotherapy, those that are on dialysis. We did this at every institution for all staff as well as inmates. Next slide.
Next slide, please.
We got into the section. As you know, we started off with regular cotton masks and our prison industries. When we got the word that everybody was short, we were running out. Prison industry, Bill Kawenga jumped in and they started producing hand sanitizers, the masks, as well as other PPE resources for us. We started distributing those to all the inmates. Each inmate, as the director explained earlier in his introduction, they received 2 masks apiece. The staff received masks as well. We started our communication as far as town halls, where wardens would meet with the inmate population as well as the staff every Tuesday and Friday. Those town halls continued as well at the camps. Now, we didn't get out to the camps every Tuesday and Thursday, but every month that our administrative staff are required to go to the camps. So when they went to the camps, they presented personally. But on the Tuesday and Thursday, whatever their agenda was that was presented at the facility level, that would be emailed. That would be emailed to the camp lieutenant, who would then also share that agenda items with the staff and inmates at those camps.
All right, next slide, please. And Deputy Director Michael Maness, who also serves as our medical director, will take the next couple of slides.
This is Michael Maness for the record. As of December 16th, 2020, the Marshall Project, which is a nonprofit news organization covering the U.S. criminal justice system. Next slide. NDOC currently is ranked 39th in the total COVID cases. Next slide, please. Thank you. NDOC was currently ranked 39th in total COVID cases nationwide. When we measure total COVID cases, Nevada is ranked 40th when the total number of COVID cases is calculated per 10,000 offenders. Right now, we're in the top 13th best in U.S. systems. Next slide. No, this one. So in accordance with CDC guidelines, I have been in constant communication with Dr. Aizen Azam from DHHS from the beginning of this pandemic. Obviously, there's been a lot of hurdles that we've had to face here at the Department of Corrections. For our quarantine, currently, those are the inmates who are symptomatic or exposed. We are abiding with CDC guidelines in that we are quarantining our inmates for a minimum of 7 days, up to 10 days or more. There is some variability there also that with our intake inmates, we have a minimum of 10 days of quarantine, but effectively it's actually more than 20 days. For confirmed positive individuals or inmates that have confirmed COVID-19 infection, our isolation time is 10 days in accordance with CDC guidelines. Next slide.
Good afternoon. This is Deputy Director Bill Poinga, overseeing prison industries. Access to screening tools, as you see here for wave one. We had thermometers that were ordered, and we're in the process of obtaining some temperature scanners that we want to utilize and set up in each of our major facilities and our camps, so that when staff and offenders come through, we can take their temperatures at a much faster rate. Access to PPE, we're in the process of obtaining approximately over 600,000 in CARES funding as far as PPE equipment, such as N95 temperature scanners. We're also going to the foggers. There's 19 facilities. We're looking to get foggers statewide. We have implemented some foggers already in the northern region. We're using the 3M tablets. These tablets are hospital grade disinfectants. It takes 1 minute kill time for COVID-19. No PPE required, 0 health rating. You can spray and go. Kills norovirus and C. diff as well. This is a real renowned name, 3M. This is also has a 5-year shelf life, and we get about 1,200 tablets, 8 tablets per gallon. We have implemented at Warm Springs Correctional Center and Northern Nevada Correctional Center, where they are sanitizing the gatehouse where everybody enters and exits between shifts, and also the units a minimum of twice a day. That also in using bleach, 10% bleach, where they wipe down areas, common areas also, but we remove the inmates to one end of the building and sanitize it with this fogger. Also on masks, inmates do not pay for face masks. Early inception of this pandemic, we issued 2 masks per inmates. They were colored orange, so that way we couldn't distinguish staff from inmates. So each facility maintains masks for both staff and inmates. There's an inventory, and each facility has an emergency operations center that keeps inventory that I check in constantly, so they need it. we can ramp up, and we hold a mass inventory at our Lovelock Correctional Center where we produce masks, gowns, and head coverings. Also at Northern Nevada Correctional Center, we offer and manufacture face shields and a lot of face masks for other entities, also in the private sector and other state entities, as well as hand sanitizer.
Next slide.
Next slide.
Deputy Director Williams, will you address this slide, please?
Most definitely, Deputy Director Williams, for the record, community restriction lifted. Basically in this section right here, in regards to community restriction, we have staff, we have inmates at Casa Grande Transitional Housing, Northern Nevada Transitional Housing, and we place restrictions on them as far as not going into the community. This is to prevent inmates going into the community, coming back with the virus. Is this for our staff or inmates, sir?
The community restrictions that were lifted in the community that had an impact on our inmate workers.
Okay.
On our inmate workers as well as our staff. I'll go ahead and take this slide. This is Director Daniels for the record. As we entered wave 2, we saw that there were some changes that we needed to adapt to. Number one, we had the entire state for the most part closed down in part or completely. But then at some point, those same restrictions were lifted to some extent. And as that happened, we started noticing that many more of our staff members started to be exposed to COVID-19, and then some were actually being identified as positive for COVID-19. That number increased substantially, and so we knew that because of this in wave 2, that there would be a greater chance of the inmates coming into contact with one of our staff members who was positive. The other residual impact of that is that we were still dealing with a relatively slow time in terms of when the person was tested and then how long it would take for them to get the results back. So for those staff members that were asymptomatic, it created a significant issue as so many more people were now back exposed to the general community. Some of their kids had gone back to school. So there was much more community interaction due to the lifting of many of the initial sanctions, which then resulted in our numbers increasing at a higher rate. We also noticed that many of our staff were experiencing COVID fatigue, no different than what was happening out in the community itself. Staff were tired, they were coming to work. In many respects, they called themselves being very diligent. I can't leave my fellow coworkers behind. They would just come to work, and we did our best to keep them out. But as the tests started to come back, we started just seeing those numbers elevate and go higher and higher. And then as such, because our inmates typically didn't go anywhere, they remained confined, our numbers started going up as well for the inmates. And of course, at the time when all of this started happening, the unfortunate part was that the amount of time that it took to receive test results back. And as a result, just like the community in general, just like the spike in general, not only in the Nevada Department of Corrections, not only in the state, but as well as the US and globally, these numbers spiked again. So we had to deal with those, we had to make those adjustments. And of course, we met with various, next slide, please. We met with various organizations. We looked at a lot of guidance, what were the other corrections agencies doing? What type of information were we getting from our friends over at the Department of Health and Human Services? And quite frankly, we're looking at all sorts of methodologies to deal with this. There's some very standard methodologies on how to deal with this, but unlike some people think, well, why don't you just deal with the hospitals or the medical centers or the homes where individuals are placed pending some temporary care? We don't have the same luxury. So let me give you an example. I can't just designate a whole wing for people that are X, Y, and Z in some respects because we have some issues that the general public doesn't have to deal with. So ours fall into two categories. Some are cohorts and some are classifications. Well, let me go directly to the column on classification. So I have to take into consideration, and my wardens have to take into consideration, the security level, not only of the institution, but also the inmate. Also the custody level. There's varying degrees of custody level. Those inmates cannot mix. So to just say, well, move these guys over here because they're positive, these guys are not, or these guys are on quarantine is a little bit more challenging. Also, there's some programming needs. We have to also deal with the mental health needs of our inmates. We also have to deal with the predatory behavior of some of our inmates, as well as gang affiliations and other issues that individuals in the private sector wouldn't have to deal with. And then while dealing with that, from an institutional and an agency-wide perspective, I still have to deal with the inmates that work in our culinary department, the inmates that are involved in vocational training. But we also have to deal with the issues that are in one of our medical units and require extended care. And we still have to deal with our severely mentally ill inmates and the inmates that are actively undergoing substance abuse issues, some that are acute and some that are still receiving treatment. When you put all of this together, we really have to manage our inmate population. With the amount of individuals that you can imagine that are especially here for violent reasons, many of them have remained violent, and we have to be very careful as to who they're exposed to and who they're celled with. So just some of the guidance that we receive all the time, well, you just do this, you just do that. Yes, we do. We do literally anything and everything that we can. However, we do have to have respect to the fact that some of our inmates cannot be around other inmates, which then further lessens the flexibility that we have within the system. We further have to deal with issues regarding transportation. Who goes where? Were they in quarantine? Were they in isolation? Were they in the hospital? All of this has an impact on where we house an inmate, how long we house an inmate, and then the modifications that we can do within each facility, whether it be an institution and or a camp. Let's go on to the next slide, please. So I'm going to transition into our isolation unit. I'm going to ask that Dr. Manel address this, please.
So this is Michael Mena for the record. In regards to our protocols have evolved from the beginning of this pandemic. I've worked closely with Dr. Azam, as mentioned earlier, from the beginning and almost on a daily basis, and really appreciated his input into the challenges that we have here. Currently, our protocols are in conjunction with CDC in terms of our isolation and quarantine times. While NDOC has been separating COVID-19 positive and COVID-19 potentially exposed inmates by way of isolation and quarantine since the inception of this pandemic, due to the rapid rise of COVID-19 infections within our facilities as late, we have, to the extent possible, taking into account safety and security issues relating to classification levels of inmates and the staffing issues, as Director mentioned, separated our inmates at all facilities into separated cohorts in conjunction with the CDC, those isolation cohort, the quarantine cohort, and the non-exposed cohort. As mentioned by Didi William Kwenga, prison industries has been very active throughout this pandemic in supplying our agency with personal protective equipment. Just recently, I had sent out a directive to all of our staff that any staff that have any close contact with inmates, as defined by CDC, within 6 feet for a cumulative time of 15 minutes or more, are to wear N95 masks at all times with any contact with inmates. In terms of the positive notifications of COVID-19 results, in the past, before we had a Quest lab that we currently have right now, we have a COVID team that has worked closely with the Nevada State Public Health Lab in notifying staff and inmates of their positive results, as well as doing contact tracing. Next slide. In terms of the intervals of our testing, that has also evolved as testing has become more readily available. Obviously, there have been changes in the time to get results for testing, depending on the state of the Nevada State Public Health Lab. Also, Quest is also receiving an abundance of tests at this time. We're currently testing staff weekly. We are testing offenders to the extent possible, focusing on susceptible inmates with chronic medical conditions. We currently have approximately 3,598 inmates out of our total population of inmates who have at least one chronic medical condition. The types of tests we have used, of course, PCR is the most accurate test. And we were previously, again, working to the Nevada State Public Health Lab to send our PCR test. We're currently working on a Quest contract, which is active until the end of December. I have been in communication with Melinda Southard just recently as last night, and there is a possibility of us receiving a sizable amount of Binax Now tests, which will help in terms of the turnover time of the testing results. Of course, being much quicker than the PCR turnover time. Again, as in terms of the notifications, staff are notified via our COVID team. The Quest Diagnostics actually has an app that can be downloaded by our staff to be able to look up the results personally, so that kind of help relieves the COVID team to perform contact tracing of our staff and inmates. In terms of notification of COVID-19 results for our offenders, we've worked closely with the AG's office in drafting an exception of AR 538 so that we can make basically print out inmates' COVID-19 results from the Quest website, staple it, label it, and then have those individual results passed out to the inmates so that we can ensure that the inmates are getting their results in a confidential manner.
Next slide, please. This is Deputy Director William Coinga. In regards to the types of PPE that we have, as I mentioned earlier, that we're always actively trying to obtain N95s, gowns, and all that. We're keeping the supply. As I also oversee the medical administration, we're looking into the temp scanners that we can get to all the facilities, like foggers, the 3M tablets. We're also using this product called Pure, which is a 3% food-grade hydrogen peroxide that we can also use, which we did deploy over at Warm Springs, which seemed to help the contamination over there. We're also looking at getting oxygen concentrators that will reduce us from having to send inmates out to the local hospitals, and we can maintain them in with Dr. Manev making that assessment with the other physicians so that we can take care of them within the house, within the department. So we're getting oxygen and oxygen concentrators so that we can maintain and keep them at a healthy level with their oxygen levels. We're looking at purchasing, and each facility is getting another inventory of oxygen concentrators. We're also looking into renting some of these oxygen concentrators as there is a mass shortage with the company that vendor that we're working with. They just can't keep up with the requests nationwide. On issuing of PPE, inmates were issued 2 masks. They can get those replaced, the arch mask, at any time, as I've mentioned, that the emergency operations centers within each facility maintain an inventory, and they can request to change those out at any time due to wear and tear. They were issued 2 in the inception so that they have one other person, and then when they have their laundry schedule, that they also turn in that second mask so that it can be laundered with their laundry and then it comes back to them. So it's not that they get 2 issued and they wear it continuously without being washed. So the reason for 2 is that so they can cycle it, so we can maintain hygiene and not spread this virus. And they're being laundered weekly. On quantities of PPE, we maintain a certain level of PPEs as far as gowns, masks, head coverings, and getting into disposable gowns for some of our medical staff and also our transportation staff, so they can dispose of these gowns and not carry them in their vehicle or take them home. So once they're completion of their transportation, they can dispose of this properly so that we don't spread that virus. We keep the inventory, distribution. I check with the EOCs on a weekly review to see what EOCs have in their inventory for PPE, so that if the institution is supplying PPE for the institutional staff, the medical division provides all the PPE for medical staff and for the inmates. But working in unison, if a facility does not have enough PPE for staff, we are on the same team, so we help each other and we provide them, and then we'll get more supplies in, and then we'll backfill from there. Exchange, as I mentioned, also exchange for PPE for staff and inmates, it's at request. Whenever the inmates need one, all they have to request from the unit officer, and they can get a supply down there, and they maintain a small amount. Same thing with hand sanitizer. Mentioned earlier, hand sanitizer is available at every facility, and I confirm this, and they are at each unit facility, at each unit at the bubble. However, it has to be requested by the inmate to the unit officer, and what we do is we give them a squirt of hand sanitizer so that they can't have, because this is an alcohol-based product. We've had some of our inmates that have ingested this in the beginning of the pandemic, and so we had to recall those back, and so now we offer it at their request to come up and get it, so it is available to them. They also have 10% bleach and cleaning supplies. They can wipe their handles and clean themselves down. The cost, we're looking over 600,000, as I mentioned, PPE through CARES funding, and also working, and thanks to Division of Emergency Management, working with Chief Fogerson, we're looking at trying to obtain some more PPE equipment from them to supply our facilities statewide, so that we stay stringent and strong in preventing this virus from spreading continually.
Next slide, please. Director Williams.
I wanted to talk about our institutional operations. Since COVID hit, we've been challenged in every which way in order to try to keep our daily operations afloat. As you know, as the director spoke on earlier, we have approximately 623 staff that have been out on COVID at any given time. Our inmate population, whether they're quarantined or in isolation, the movement has been restricted. So we've been very challenged at the institutional level. But some things we just have to do. We have to feed them 3 meals a day. And in doing that, staff, whether it be officers or our free non-uniform staff, have combined their efforts to prepare meals. Most of our meals before the pandemic, we served in the culinary. Since the pandemic, we've been serving in-house to the inmates in their cell. Staff wear the proper PPE when serving meals. If they happen to come in contact with any inmates, they have to change out those PPEs. That slows down the daily operations as far as being able to deliver to the housing unit, then prepare the meals, put them on trays, and then deliver them to each inmate. Inmates are also, depending on if they're in quarantine or isolation, if they're in isolation, we give them showers every 3 days or every 72 hours. If they're in quarantine, we normally let them come out in groups of 4 to 6 inmates at a time to shower. Phone calls, phone calls is tied into our out of cell time. So phone calls, when inmates have their out of cell time, that's their opportunity to also take showers as well as make their phone calls. The out of cell time varies between facilities. Some facilities have various classification levels of inmates as far as their levels. Therefore, it makes it extremely difficult to have them all out at any given time, depending on what facility it is. So it varies. Some facilities are able to give a lot more out of cell time. Some facilities, we're trying to give at least a minimum of 30 minutes out of cell time. But again, a facility like Warm Springs, where the COVID hit the entire facility, they probably didn't get any out of cell time during that time due to everybody being on lockdown and restricted movement. But as a department, we're trying to give at least a minimum of 30 minutes a day out of cell time. Our programming was continuing. Although it was limited, we were still conducting programs. When we got hit in November with COVID and our numbers started to skyrocket, as you know, most of the facilities were locked down. At that time, our programs was suspended. As things start to get better, for example, Florence McClure, they're starting their substance abuse programming back up. We'll start our reentry efforts back up with our staff, and we'll start our programming. Before November, we were talking about trying to get our education back in. I know some districts are prohibiting their teachers from coming into the facility. Some districts will still allow. We also have some NDOC staff that also work for some of the school districts. So they were able to still continue providing programming. So as soon as things open up again or the restrictions lifted, inmates are off the lockdown, our programming efforts will continue, whether it be mental health, reentry, or substance abuse. And then we'll move forward from there as far as trying to get a plan in place to continue with our education. Staffing, I don't think our staff get enough credit for the things that they're doing. We have a lot of staff out, again, about 623. And then we have some staff that are continuing to come to work. They're working 16-hour shifts. They're fighting the fight for our department. And I know I heard a lot of the public comments. Our staff are doing everything possible to continue with day-to-day operations. And we're challenged, we have obstacles, but they're continuing to fight the fight. They're continuing to come to work, and they're continuing to do the things that's necessary for us to continue to operate the facility. It's very challenging. We're pulling staff from here to there. We have inmates going from Warm Springs over to NNCC to assist them now. Lovelock Correctional Center is struggling. We're trying to get staff from NNCC and Warm Springs to go there. It's like we're running from Peter to pay Paul in order just to survive, and our staff are doing a great job, but it's challenging, and we'll continue to fight those challenges and fight the fight until this thing is over with. Next slide.
All right, thank you.
Hi, this is Director Daniels for the record. At this time, I would like to take a moment to address public comments. As director, I am happy to meet with advocacy groups. However, my responsibility is to lead the department. This requires me to put my focus and energy into implementing and evaluating policies and procedures related to public safety, staff safety, and offender safety. We are also in a pandemic, which has required a all hands on deck 24/7 mentality. I started roughly 1 year ago, and the pandemic hit in March. I appreciate the concerns and questions presented by the public. Further, advocacy groups have various ways to be heard by me, even without face-to-face meetings. Letters and phone calls to appropriate representatives and submission of public comment and questions at events such as Board of Prison Commissions meetings, sentence commissioning meetings, and other public forums is available to everyone. They also have the opportunity to discuss concerns with their elected officials. As I serve at the pleasure of the governor, it then becomes my responsibility and duty to implement the policy visions of the governor consistent with sound and effective correctional policies, and above all, the constitutional rights of all inmates. As director, I have no issue with anyone seeking release within the scope of the law. Further, elected officials are always welcome to take a tour of any NDOC facility. Inmate Early Release Authority is governed by state statute, specifically NRS 209-3925, which is residential confinement. I encourage all to review the statute to have an informed understanding of my authority to grant early release. In closing, I am proud of the work of the fine men and women of the Nevada Department of Corrections. Every member of the agency was designated essential and have worked tirelessly to keep the general public and inmates safe while enduring the same challenges faced by the public in general. NDOC staff do not work from home or otherwise telework. Prisons operate 24 hours a day, 7 days a week. Corrections staff serve as 911 for one another and the offenders. I am extraordinarily impressed with the dedication and the professionalism of each and every one of my staff. In closing, I will share with you this. This is very challenging work. My staff have risen to the occasion under extraordinary conditions.
if your thoughts of perfection is what you want out of this agency, I'm going to ask you just to reevaluate it, because if you are somehow flawless in whatever you do for a living, I appreciate it. Maybe you can help us out. But these men are dedicated. Many of them haven't had hardly any time off since we started. They do whatever it takes to get here while dealing with the same childcare, medical issues, deaths in their family, and so on. And they rise to the occasion every single time. Once again, this is not the perfect business, but we strive to do the very best that we can. That standard will not be degraded at any juncture in the future. We will continue to do what we do. So, in support of my staff, those hardworking, dedicated professionals, whether it be from medical or from the correctional services side or prison industries, I commend you. And although many people want to claim that you are not professional and you don't do your work, I reject that wholeheartedly. If you want to condemn me, or I'm fine with that, I've got it, but my staff are first class. And they're always running into danger and working conditions in conditions in which most people would have no idea how to handle. So hats off to my team. I also want to thank Director Cage for running this meeting. This was an opportunity for us to be able to share what we do in spite of all the negative press and the negative comments, many of course, which are baseless. I will now open this up to questions.
Thank you, Director Daniels. I appreciate that. And let me first just say, before we open it up to questions from the task force, first and foremost, thank you to you and your team. I want to be clear on that. This is an extraordinarily difficult time to be in public service in general, and I think that the challenges and various hazards and everything related to what you do and what your staff do at your facilities do point to an extraordinarily difficult time during this, especially during this pandemic. So I just want to be clear, and first and foremost, thank you. And I've worked with some of your command staff there, particularly Dee Kwanga for several years now, and know the quality that they bring to the table as well. So I appreciate your willingness for putting this presentation together. I think that we all know that there are, we need to have conversations publicly about this, and to look for opportunities for improvement. As you noted, if there are opportunities, then I know we would all be for them. And I know some of the ongoing collaboration between your staff, your team, your leadership team and staff there, and organizations like DEM and DHHS and others can be highlighted as well. So first, just want to thank you and your team for what you do. Second, I want to thank you for being open and willing to come here and shed some light on the situation here in the state. And I'll ask some questions later, but I know members of the task force would like to as well. And I know everybody's got limited time here, so but this is so important. We want to make sure that we can present and have a good discussion. So from there, I'll open up the discussion to members of the task force who may have questions.
This is Melissa Peak-Bullock, state epidemiologist for the record, and thank you for the presentation today. I do have a couple of questions to ask quickly. The first is on slide number 3, where you're presenting your current numbers of staff and offenders. In looking at those numbers, it's not clear to me what the time frame is for counting these. They're not the cumulative number that's over 3,000. And I know in your presentation, you referred to these as current numbers. So I'm just curious if you could share your definition of what the current number means, if you have a methodology for pulling out current versus cumulative numbers.
This is Michael Minev, Medical Director for NDOC. There have been delays, obviously, with reporting some of the numbers. We have had, obviously, the logistical challenges of getting the numbers compiled from all of our facilities statewide. We have been trying to be in communication with not only Dr. Zahn, but Director Whitley, as well as General Counsel Kevin Benson, and others from the DHHS in regards to daily reports and the positives that come up at our facilities, as well as the issues in terms of the clinical status of some of our sickest inmates and such. Can you repeat your question again in terms of?
Absolutely. My question is really, how are we defining the current cases? They were referred to as current cases versus cumulative. So I'm just curious how you're pulling current cases from the cumulative number.
So our cumulative cases are the number of individuals that have tested positive since the beginning of the pandemic up to this time. Now, some of the individuals in accordance with CDC guidelines, some individuals that have tested positive for COVID-19, whether those are staff or inmates, can be cleared after a 10-day isolation period if they haven't been hospitalized and if they have been asymptomatic for 24 hours at the end of the isolation period. I have extended the asymptomatic period of time to 72 hours out of an abundance of caution. But it's per CDC guidelines is for 24 hours. So I think that some of the confusion that people are seeing is that they see a spike one time from one of our facilities will get infected, and they see the spike in the number of cases, and then suddenly a couple of weeks later that number goes down, and that's because those individuals have cleared the isolation period of time. They haven't been hospitalized. They were asymptomatic at the end of the period. And so they're now counted as negative because they have cleared the COVID-19 infection. Does that answer your question a little bit better?
Yes, it does. Thank you for that. And then just one other question on the data. I noticed and I think I know the answer, I just want to confirm on the isolation for staff, the number of staff in isolation is greater than the number of staff that are positive for COVID-19. So I was just wondering if you could speak to that.
That could be an error. Those numbers should be identical, because if you're isolated, you should be verified as a COVID-19 positive. So thank you for bringing that to my attention.
Yeah, absolutely. And just one more question. I just wanted to confirm, based on what we heard today during public comment, are there any inmates that are part of any community work programs that are going out into the community, such as through forestry or other mechanisms?
Deputy Director Brian Williams, we do have inmates going out, and they're going out with the Nevada Department of Forestry, and they're basically doing, what do we call it? Brush removal or brush remediation, and they're normally in remote areas away from the public. We did have a crew go into town that was not authorized, and our warden dealt with that immediately. But normally we have about a 1 mile radius that we don't want them to have to come in contact with any humans. So they're normally in the forest doing remediation in the forests and clipping trees and removing things from the forest as far as limbs, branches, and things of that nature. But they are going out.
Thank you.
Thank you for the questions, Melissa. Other questions from task force members?
Hello, this is Terry Reynolds. I wanted to ask on the, what is your authorized employee count and what's your actual employee count right now within your facilities?
This is Christina Leathers, Chief Human Resources Officer for the record. If you give me a moment, I'll look up the exact data as of in the system today, and I can give you the answer to that.
Okay, thank you.
And Director Reynolds, will you have a follow-up on that, or is that your question?
Caleb, that's my question. So if you want to go on to another question, then she can return back. That's fine.
Great, thank you, sir. I believe Melinda was going to offer some input.
Yes, thank you. This is Melinda Southard for the record. I just wanted to state, Director Daniels, thank you for your presentation. And I just really appreciate the responsiveness and partnership with Department of Corrections in ensuring that we do have testing capability provided, and just appreciate all the communication and collaboration with Dr. Menev. Just thank you.
Thank you very much. This is once again, Director Daniels. I'd like to thank you for your comment. We have a lot of moving parts over here, and unlike many departments, some of the people we have in our custody don't want to be here. Cooperation sometimes is a little waning. Nonetheless, we strive to do the very best that we can. We really enjoy our partnerships with our fellow organizations within state government, all of our folks involved in public safety, and also the folks over at the governor's office who do a tremendous job in support of us. And they've been there every step of the way. So thank you for your comment.
Kyra, go ahead.
Hi, this is Kyra Morgan for the record with DHHS. I just had a question. On slide 6, you put up some data that ranked our state Department of Corrections against a number of other states. And I think we were coming in 39 or 40th when we look at both the number of inmates that have contracted COVID, and then also I think you had that displayed as a rate per 10,000. I'm wondering, when we look at specific facilities that we have, you know, upwards of 80 or 90% of inmates have become infected, I believe, that implies to me that we have other pockets of facilities that are potentially doing very well in order to offset that and put us at an average that's actually, you know, seems good compared to a lot of other states. I'm wondering if you've looked into the differences between those facilities. Like, have we done any kind of root cause analysis? Are there fundamental differences between the facilities that are performing poorly and facilities that are performing well? And then, you know, if that's taken place, have there been any strategies identified that we could potentially, you know, help to make that more even keel across the board?
I'll start off. Yeah, there are many factors. And yes, part of what we actually do is we assess routinely, whether it be safety and security wise, or violence, no matter what it is, we assess. Well, in many of our facilities, we don't have a basic cell type structure. Some of them are, for the most part, open bays, or or they're in areas in which typically, because of the size and the location and the security level, the inmates have much more access to one another than they would in maybe some of the other environments. So if you were to add that into a lot of the other factors that go into play, we can't use this unit over here, and there may be 7 or 10 or 12 extra cells because all of these guys are max custody and or they're very violent inmates. In spite of the fact that we may have more inmates, those guys are sequestered much more, meaning the other guys at the other places, there are more inmates that are out and about. Also, the larger the facility, of course, the greater the opportunity for the inmates to come into contact with someone that is COVID positive, even if they haven't tested positive. That's just the nature of the beast of having so many inmates and so many staff in places that are designed to have inmates in close quarters. Our average cell size is roughly 8 by 13. Now, if you compound that by a more higher security level cells and how they're designed, there may be a little bit closer, but our bays are open. And then, of course, some of our inmates do go out at our camps to support NDF, and what they do is very important. So there's a lot of moving parts. We have women's facilities, men's facilities, maximum security, minimum security, and medium security. And then within each of those operations, there are subgroups and subcategories of individuals that have to be separated from others, which means some of the inmates are more densely compacted and we can't move them or we can't do a lot. But when we do, then we'll even change the designation of an entire housing unit, 1 or 2 units at a time, and just transition it from a general housing unit to a quarantine unit. And then in some instances, even adapt it to an isolation unit. But typically, a lot of that happens after we find out we have an issue. This is a lot of moving parts. This is, as I had mentioned earlier, some people just think, well, why don't you just put these guys over here and put these guys? No, we can't. Some of these guys will hurt one another really bad. We can't, just can't do it. But most people have no idea what it takes to be able to move people around, considering all the variances in their security level, violence, proclivity, or whether or not they're vulnerable to the predatory inmate. All of that has to happen, so it depends, is the real answer. But I assure you, we assess it routinely. That's my Deputy Director of Operations, that's his job, as well as my Deputy Director of Programs. And we keep a good tab on that, but it's not as easy as just saying, all right, let's move these guys over here. We may not have any space, so we have to do the best that we can do. I also believe that Dr. Murnell wanted to add into that response.
Well, just to kind of piggyback off the director's answer, for instance, Warm Springs, we had the majority of our inmates were were infected with COVID-19, and luckily, the vast majority of them have successfully cleared isolation or asymptomatic and are healthy, and they've opened up the yard in modified operations. So one of the strategies that I've been kind of communicating with the warden at Warm Springs and NNCC is to the best of our ability, take custody staff, for instance, that had been tested, that had been infected with COVID-19 from Warm Springs that have cleared infection, and have those officers work at units within NNCC where we have a very vulnerable population of inmates because of many of them having multiple chronic medical conditions. So in other words, having those staff that have cleared infection work at NNCC because they have basically a very low risk of getting COVID-19 again and spreading it to our vulnerable population. And also vice versa, where NNCC, for instance, is an intake center, and they were running out of room in their intake center the other day, but they had some inmates that were still on quarantine, and we basically took those quarantine inmates from NNCC and moved them to Warm Springs, so that even if they were potentially hot, because all the inmates at Warm Springs had already been infected, there's a much lower risk of causing basically mitigating the COVID-19 spread by swapping staff and inmates in that manner.
Thank you. I do have one follow-up. So it sounds like there's, a number of things here, correlation in size of facility, types of prisoners and different security levels and things like that. I'm just wondering, and I'm coming at this from an HHS perspective, often, especially with COVID, we've had to really reevaluate the way that we do things from a capacity perspective as well. And part of that for us is always reaching out to other states and kind of seeing if they've found things that are working, maybe that we don't know about. And since we're ranked, 40, maybe 39 other states are doing worse than us, so that wouldn't be a great idea. But I'm just wondering if we're trying to work with other states, have other states been identified to be most successful? Are they doing anything differently? And just really what does that look like? What could we do, I guess, is where I'm going with this.
Hi, this is Director Daniels. Yes, we have monthly meetings with all the directors. All the directors belong to an association, and we share ideas. We have access pretty much to what anyone and everyone else is doing. None of this information about how to manage your inmate population specific to COVID is done in a nutshell. We all share the same information, we all know. For the longest part, especially during wave one, we were typically 1, 2, or 3 in any type of category, meaning that we were on top of the game because we understood the value of prevention. And so we established what we call the firewall technique. And then as the inmates moved, they all went in, no matter who you were, you went into an intake unit, and that intake unit was quarantined. And then if anyone tested positive, then we turned it into isolation unit. However, over time and the articulation of our staff that go in and go out, just over time, we knew that this would happen. There was this hope for a vaccine as soon as possible. But at the end of the day, when you have humans in close quarters and you have staff, and since nobody turns polka dot or purple when they get it, you're just doing the best that you can. And many of those other states adopted what we did. But as time went on, most of it became the management. You look at your system, not only at institution, but the entire agency. And then you try to put people where they can be. But once you start moving inmates around the organization, and since we don't necessarily know who has what because of the initial delays, then you have the possibility of moving it from one facility to another. So there's the management of the state and all of our resources and all of our locations. Then there's the management at each individual facility. We were pretty proactive in being able, our staff, our wards are very flexible, as well as our medical staff are designating, listen, we got to take this offline. We got to make this a quarantine unit. We're very good at that, but we all will almost always have to do that after the fact. Why? Because we're having to move entire populations based on the other factors, the security, whether we have vulnerable inmates, do we have violent inmates, do we have all of those other deals that are going on, do we have inmates with chronic illnesses, do we have inmates that are pregnant, we have a lot of other factors. So most of what we do is because we've worked closely with our experts here in the state, but we also are keenly aware of what others are doing. But once again, you may run into a system where they don't even have a maximum security prison. They may have a high security or medium, but they don't have, it just depends where you are, local circumstances, the amount of inmates. I looked at an agency that had 27 facilities. This one has 17, and that includes our work camp. We legitimately only have 7 of our larger types of facilities, 7 or 8, depending on how you classify one of those. So we just basically do the best that we can. And we are very, very good at being flexible. Once we're aware of a spike, we respond to it. Once again, that delay in knowing who has what has always been the scourge of any corrections organization. But no, we communicate regularly. I'm aware of what the other agencies are doing. The other agencies are aware of what we're doing. I see us as the corrections community, not just our state corrections. We're the corrections community, and we do share information all the time. But once again, and I'm certainly not suggesting that you do this, but I get calls of people, well, why don't you do this? Because the hospital over here does this, or the medical center. Well, we can't just sequester a wing and say, all right, you folks over here are this. No, it's much more complicated. Having said that, the challenges are what we rise to the occasion on. But I would just ask that people just reflect. The President of the United States had COVID. This is a pandemic. It's everywhere, and our inmates are in close quarters, and they don't want to be here. We get it, but we're doing the best we can to take care of those inmates. I have relatives that are incarcerated. I don't want anything bad to happen to them. And you know what? I can speak for myself and the other directors. We do pretty much everything that we can, and we reach out all the time. And we're very open to suggestions and recommendations. But typically, I find that those suggestions and recommendations don't take into consideration the challenges that we have with the type of clientele that stay in our prisons. So thank you, though, for your comments.
Thank you.
This is Christina Leathers, Chief Human Resources Officer, Director Reynolds. To answer your question, NDOC currently has 2,971 authorized FTEs. As of today at 9:31 a.m., 2,594 of those are currently filled, and that does not include any new hires that we had start on Monday of this week.
Thank you.
This is Julia. I just had a quick comment and then a question. The quick comment is I just want to acknowledge your prison industries. Early on in the pandemic, and you all spoke about it, we were hurting in Nevada for hand sanitizers, PPE, and prison industries stepped up beyond. So I just want to acknowledge all of the staff and inmates who did that and are still doing that. So just want to put that out there. And then you noted that you had paused programming for a number of reasons. As you look at opening program, because some of this is just offering inmates, it sounds like, time outside of the cell, understanding there's many issues associated with that. So I'm oversimplifying it. But as you look at opening programming, is there opportunity to look at telehealth, teleeducation, doing it in some capacity truly to redirect energy and effort. And then as far as getting outdoors and exercising, as was noted in one of the public comments, are those types of activities that you can look at when we get the infection rate down? Again, just to allow those inmates some time outside of the cell. Thank you.
Director Williams, for the record. We are looking at that. We currently do have some virtual classes going on with our reentry. We were working with the various school districts to try to bring equipment in. We're working on a current NRS right now to allow internet inside our facilities. That way we can do virtual learning and things of that nature. We're also looking at tablets coming into our system. So there's a lot of things that we're working on currently to bring and provide more services to the inmate population. As it relates to out of cell time, a lot of our facilities are able to offer a lot more out of cell time than others. Some of our facilities, which have a very, like I said, various classifications of inmates, they just can't do it because of the restricted movement, quarantine units, isolation units. We just don't have the staffing to be able to keep up. So we actually have staff floaters going from one housing unit to another housing unit to allow inmates out to recreate, get on the phone, take a shower. So we're working it the best that we possibly can, but I am in constant communication with my wardens to ensure, look at every possible means. Think outside the box as far as how we can get the guys out of their cell, get them some rec time, let them communicate with their families. Over the last 20 days, I've hit every facility in the state, all our major facilities in the state, just to ensure that we're doing everything possible, that our staff are doing what they're supposed to. And I've reported back to our director, our staff are doing exactly what they're supposed to. It's just, it humbles you when you look into a group of officers' eyes and they're working 16-hour shifts today and they're fighting the fight. And what can you say to them? I mean, I appreciate you. Thank you. I love you guys. You guys are doing a wonderful job. And then to come to a forum and then, you hear the public comments and the comments being made. Our staff care, our department cares. We're doing everything we can to try to fight this. For 7 or 8 months, we were the best. We were doing the job. But at the same time, fatigue, you're burnt out, things start to set in, and it's unfortunate, but it got in, and now we're dealing with it now that it's in. But rec time, virtual classes, we're looking at all those things. Before I took this position as Deputy Director of Operations, I was the Deputy Director of Programs, so I was working very closely with the higher education as well as the school districts as far as how do we get you guys back in to provide services. And although we don't have the virtual learning portion, we were still meeting with the teachers, getting work packets to give to the inmates. The inmates complete the work packets or the educational packets, and then they send them back. Our staff at the facility was working with them, monitoring it as well. So it's been a family affair as far as all working together to get through these times.
Great, thank you so much.
Additional questions from members of the task force at this time?
Go ahead. Director Cage, this is Deputy Director Quang. I just want to make a comment in regards to the last question. Also in prison industries, we have a welding program and some other courses that we're working with at Western Nevada College. As of today, and we're still continuing since the pandemic, we are receiving the curriculum in, and I have the prison industry supervisor in the north that is collecting that and handing it out to the inmates so that they continue their education and still working with WNC and working with WNC through the supervisors to enhance their education and continue it as we go, even through this pandemic.
Thank you, Mr. Quang. I appreciate that. Lisa.
Hi, Lisa Sherrick for the record. I just wanted to just make a comment that we are going to be meeting with the Department of Corrections tomorrow just to further see how we can talk through some of these things and be able to provide any additional support. Understanding, as Director Daniels mentioned, they do have some uniqueness to their facilities compared to hospitals and so forth, but we are more than happy to continue to try and figure out ways to help them in this situation. So I just wanted to let folks know that corrections is really, working with us to address these issues.
Thank you, Lisa. Other discussion from members of the task force? Okay, hearing and seeing none. We want to say once again, thank you, Director Daniels. We'll certainly be following up with you and your team, and I know there's a lot of collaboration that'll be going on ongoing from here. We appreciate the time you've invested in this meeting today, and for the work you all do. I know there will be plenty of conversations going forward as we continue to address the different elements of this pandemic, to include the ongoing vaccination efforts that got underway this week and so on. So really appreciate your time and your team's time today and answering the questions that we had. And with that, I'll go ahead and close out the agenda item number 8 and move to agenda item number 9. So thank you all very much. Agenda item number 9 is public comment. A reminder that no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. Public comments will be limited to 2 minutes per person. Comments will not be restricted based on viewpoint. Because there is no physical location for this meeting, public testimony under this agenda item may be presented by phone through the information provided in the agenda. I checked earlier, and it looks like there was about a 23-second delay between the meeting that we're attending here on Zoom and its broadcast on YouTube. So I want to make sure there's plenty of time for members of the public to call in, to provide comment, and also to remind everybody who is a member of the task force or a member of the public that there were 6 additional pieces of public comment that were submitted separately and via email and are available on the Nevada Health Response website for this meeting. If you are here to provide public comment, please remember to mute yourself unless you're providing that comment. If you are providing that comment, press *6 to unmute yourself, identify yourself and provide your comment, and we'll stop you at the 2-minute mark. So please proceed with the first public comment.
Hello.
Mr. Chairman. 2
Hi,
people there. Go ahead. Go ahead, Denise.
Thank you. Hi, my name is Denise, and I am with Return Strong, and I would like to just speak for the record and address NDOC as you so eloquently addressed us, the people of the public and constituents of this state. Thank you, Director, for the same exact statement to the people who commented today that you used last time. We heard you last time and we hear you today. I would also like to say that continuously showing how Nevada is doing in comparison to other states regarding COVID-19 in prisons does not count when you have not tested 100% of the prison population. It's common knowledge at this point that people can have COVID-19 and be asymptomatic, which would mean that someone not showing symptoms would be able to then infect someone who could potentially become severely ill or die. But the precautions there couldn't be taken because of your current testing guidelines of only testing those with symptoms. I would be interested to see how Nevada Department of Corrections would fare on these same statistics after 100% of its incarcerated population is tested. And to answer Kyra's question, yes, there is a discrepancy facility to facility because its entirety has not been yet tested. Thank you for your time.
Thank you, Denise. Additional public comment?
Mr. Chairman?
Yes, go ahead.
This is Lee Hoffman calling from Elko. I want to thank Dr. Pandori for his presentation regarding cycle thresholds and the clarity that that provided. I hope it enlightened the task force, or at least some members of the task force as well. It leaves still a couple of questions unanswered. It was very illuminating, but it leaves a couple of things unanswered. There have also been questions about the specificity of the tests, and that remains an open question. It made me, and this is a curiosity question that I will try to research on my own. it made me curious whether another variable between the various test methods is the measurement of the fluorescence, if there is a standard for that, or if that's another variable between the various tests. But most importantly, he discussed the reasons why cycle thresholds, the count, can't be used as a diagnostic at this point in time. It seems to me important that the Department of Health would be collecting that data so that in the future, that data can be used to help assess the cycle counts as part of the process. Thank you for your time.
Thank you, Mr. Hoffman. Next public comment.
Yes, hi, my name is Nicole. I'm calling with Return Strong. And again, I would like to address the fact that the complete blatant lies that have been coming out of the Department of Corrections is it's absurd. First of all, programming has not continued to continue for every inmate in the police. Most of High Desert has not had programming. In addition to, sports teams are able to get tested 3 times a week, yet they said earlier that inmates are to be tested every 3 weeks. It was reworded today to state every 3 months. However, my husband, who is sick in High Desert, has been sick for over a week and a half, has not been tested, even though they have been made several times aware to not only the warden's office and medical, to the staffing sergeants, to the public information office, as well as the Southern Nevada Health District, who said it's out of their hands as it is no longer is a state agency. I just don't understand how we can blatantly listen to the fact that everything that comes out of their mouths is not accurate information as presented even in their PowerPoint this afternoon. Like I've said before, everyone is not being tested. That is why there are pockets of good information. It is not because there's actually healthy people and that the facilities are not having issues. It is because they are not being tested. Thank you.
Thank you very much, Nicole. Is there additional public comment at this time?
Good afternoon. My name is Jenna. Can you hear me?
We can hear you, Jenna.
Okay, my husband is incarcerated at High Desert State Prison. I'm a member of Return Strong. I'm here today to just talk about what's been going on in the meeting. In August, Daniels implemented a testing procedure that would have had incarcerated people tested every 3 weeks. That never happened. Our people inside have been documenting when they were tested and how they were tested, because if you do the test improperly, you will get a false negative. We have tracked the daily reports of units being quarantined due to possible or verified cases and checked the data against the DOH tracker, and they never even come close to matching. We understand tests can be in process and delays in processing, but something never adds up. Yes, a couple of weeks ago at the sentencing, Commissioner Daniels stated that there were 5 deaths due to COVID. Why are they never reported on DOH tracking? Today, there was a report that 8 people have died in the NDOC, and it finally was tracked. We need an independent investigation. We need 100% testing. Why is Daniels only doing 100% testing at facilities with 300 people? We want to see the numbers at High Desert State Prison and Southern Desert Correctional Center. 90% of 4,000 tells a way different story. What are they hiding? And I'm done.
Thank you very much, Jenna. We'll go to the next public comment.
Hello.
Hello. Please provide your public
Hi,
comment.
my name is Monica. I am a member of Return Strong. I just wanted to address a couple of things that Director Daniels had said. First, our loved ones have not been getting any type of packet for education. I also want to address the fact that if this situation was under control, why was 90% of Warm Springs Correctional Facility tested positive, including my husband? High Desert has not been tested positive, or has not been tested at all. There are still loved ones in there that are sick as we speak and have yet been tested or been treated or given any type of medication for their symptoms. You say that our loved ones are getting tested every 3 weeks, but yet my husband was tested November 25th, which came back positive and has yet to be tested again. I just really want to figure out why these lies and not the truth has not come out from NDOC. And we are just want answers, and we want the right answers. We want the truth. for our loved ones, because they deserve it and we deserve it as well. Thank you.
Thank you, Monica. Is there additional public comment at this time? Is there additional public comment at this time?
Yes, hi, this is Nicole again with Return Strong. Apologize for hung up earlier. I would just like to also address the fact that the new numbers for today, I find it odd that they chose the dates a few days ago to present their current numbers, when in fact in the last 3 days, there's been additional 800 inmates testing positive just in the last few days. And that is just, so the total is now 2,442 in the state of Nevada Department of Corrections. In addition to that, the people who are not receiving programming are earning an extra 5 days added to their sentence for every single month that they are not there. So therefore, in the past 9 months, they've added at least 45, 50 days to their sentences for stuff that they're out of their control. And I think that needs to be addressed as well. Thank you.
Thank you, Nicole. Is there additional public comment at this time? Additional public comment at this time?
Hi, this is Leslie Turner again with Plan Action Las Vegas. And I just I've sat through the entire meeting, so thank you all for your time and thank you for, fighting for our health here as Nevadans. And I just wanted to address a couple things. One is that we've received hundreds of letters from incarcerated people, many of which have been read on these calls and other calls. And so they're not baseless. They are the experiences of human beings. And it's important that they are considered just as valid and just as important to look into as this PowerPoint that we just sat through given by NDOC. Also, this isn't to attack anyone. This isn't to attack officers who, go into these facilities and do their jobs. This is to report what we're hearing and what we're seeing and to save lives. This is about preserving human life at the forefront. So I just wanted to really just give that context and really just urge this body to take seriously the accounts of incarcerated people that we're sharing with you all and figure out what can be done and how can we bridge the gap between what's being reported by incarcerated people and what NDOC is saying is occurring. Thank you.
Thank you, Leslie. Is there additional public comment at this time? Not hearing any additional public comment, I'll remind everybody that there is public comment provided to you in writing that was included in your packets this week and in the minutes. These public comments will also be provided in the minutes next week as well. Appreciate everybody's time today. I know everybody's extremely busy. Right now, I'll close out the public comment section and we will go to adjournment. Is there a motion to adjourn?
I make a motion to adjourn. This is Richard Whitley.
Thank you, Richard. Is there a second?
Fogerson, I second.
Thank you very much. All those in favor, please signify by saying aye.
Aye.
Any opposed, vote no. Thank you, everybody. We'll see you again soon.